resecting the tumor. He's finished the superficial part. Even though the orifice was away, as we resect the deep part, you can see the ureteric orifice. That's the ureteric orifice has been dissected with TURBT. So how do we go about such? In a study where all the tumors which were present at the ureteric orifice were studied, and the pure cutting was used for cutting the ureteric orifice, and also they avoided excessive coagulation, and they did they preserved the urethral patency. In this group of patients who didn't have prior hydronephrosis, 13% developed new hydronephrosis. Out of it, 4% reduced spontaneously, but 4% had true stricture. So why don't we stunt very regularly? The main reason being the DJ stunting increases the chances of metachronous UTUC. So that's the main reason we don't stunt every patient. But there are special situations wherein we may need to stunt, such as the previous video which we saw. There is complete orifice resection. If there is a pre-existing hydronephrosis because of muscle invasive bladder cancer, where the tumor is invading the muscle, so in those cases we need to stunt. And also in case of during TURBT, if there's excessive coagulation or fulguration of the ureteric orifice, those people also needs to be stunted. The next challenge is the operator jerk. So better to prevent before it starts. So it's the main strategy being don't fill the bladder too much. At least less than 50% the bladder should be filled with saline or the irrigation fluid, sorry. And reduce the cutting current whenever you're doing a lateral TURBT, a tumor on the lateral location. And also use short intermittent burst. You can see over here, since the surgeon is using the current very judiciously, you can see the operator jerk. So this, what happened over here is the loop went in directly into the deeper layers, and you can see the perforation. So using short intermittent bursts and as well as bipolar resection may prevent from TURBT. So in the past, we have known that spinal with operator nerve block is the way to go for preventing operator jerk. It reduces the incidence of operator jerk. It reduces the bladder perforation risk. It helps in complete resection, and also 12-month recurrence is also reduced. At our center, we routinely use GA with neuromuscular blockage in case of large tumors, lateral wall tumors. So this also helps in reducing the operator jerk. So how do we would have all faced a situation wherein you're doing a TURBT and there is excessive bleeding. So before we go into the way to manage it, let's see the preventive strategies. So first, always make sure that irrigation is continuous and your assistant who is changing the irrigant to irrigation fluid to be very wise and change regularly. Avoid overdistension of the bladder. Resect from the periphery, then come to the center, and coagulate the tumor base, and also use bipolar energy source because it achieves better hemostasis. Over here in the video, we can see the surgeon very nicely resect the tumor from the periphery coming towards the center. And every attempt to resect is coagulating it at every level so that the bleeding chances are less. So this is about the superficial resection. When we are doing a deeper resection where we trying to take the muscle tissue, it's always better to do a short intermittent burst like as shown in the image. So you'll have a better quality of muscle specimen, no excessive charring. And also you can see some operator jerk as well as he does it. So since he's doing a short burst, the lesser chances of the loop going inside and causing perforation. So if you now we saw the preventive strategies, let's talk about a scenario wherein you have gone in and it's excessively bleeding. So how do we overcome this? So first, always check the irrigation fluid whether it's going in and the irrigation fluid is coming out. The main reason being either the assistant is not changing the irrigant or there is some blockade in the outflow and the inflow. So either the TURP chips or the clots can also cause decreased outflow. So also identify the bleeding source by not over distending the bladder and with low distension. Try to use electric cautery, either loop or a ball electrode, and coagulate the bleeding areas. If you are if you think you are not able to achieve hemostasis, don't go for deeper bites or don't try to resect more. Try to stop the resection, achieve hemostasis, then come back. And also try to always keep the bladder pressure low and use other energy sources like bipolar TRBT, where better vision can be achieved. And also, if the bleeding further persists, better call for help, stop the resection, put a catheter, come back another day. So coming to bladder perforation, the incidence is about 1 to 10%, and most of the time it's extraperitoneal because we get tumors located in the lateral or the posterior wall, very common. Less tumors we see in the dome or the anterior wall. So how to identify it? So if you see a yellow perivesical fat, then you have to think about perforation. Or you see a dark cavity between the dextrosa muscle, or the irrigation is going in but it's not coming back, then you always think that there is a perforation. Along with that, abdominal distension, hypotension, tachycardia all suggest there is a perforation. So since most of the perforation is extraperitoneal, how do we handle this? So if you can resect, better to stop resection, achieve hemostasis, assess the perforation, put a large bore catheter, keep the catheter for 7 to 14 days until the perforation heals. Before removing the catheter, make sure you do a cystogram, see if there is no perivesical leak. Sometimes it cannot be so simple. Sometimes there can be extravasation of fluid into the spaces. So during those time, we may have to put a drain. What about intraperitoneal perforation? Stop resection, assess the abdomen, and immediately do a cystogram on table, or do a laparoscopy, diagnostic laparoscopy, look for the perforation, do a surgical repair, either open or laparoscopic, and keep a peritoneal drain placement. In this study, where 150 patients had perforation, 86% were catheter. 86% of patients had only catheter being placed, and they healed well. 8% underwent tube drainage, 4% had surgical repair, and 1 to 2% underwent cystectomy. Even though we think by perforation the tumor cells may enter into the intra-abdominal cavity, it can be a T4 disease, but certain studies have shown that there is no significant difference in recurrence or progression following a perforation. So there are many strategies in such patients. We think of neoadjuvant chemotherapy, or we also think of installing some peritoneal cavity chemotherapy agents. Next talk about bladder diverticulum, or tumor located in abnormal positions. So the main challenge with bladder diverticulum is the no muscular dyspropia. So the wall is thin and sometimes the narrow neck. So the TRBT instrument cannot you may not reach the target. And also difficult assessment whether it's invading the deeper layers, and also visibility may be obscured. So how do we go about? If you have a small tumor which you think it looks low grade, better to carefully resect it, making sure not going too deep and not worrying about taking muzzle, and also give intravesical therapy based on the risk stratification. If it's a large tumor, better to go for a diverticulectomy or a partial cystectomy or a radical cystectomy. So most of us would have experienced bubble explosion in our practice. So this is the most common scenario wherein you're trying to reach the dome tumor, you're trying to resect, but there's a bubble explosion. So why does it happen? Mainly the hydrogen gas which is released due to tissue pyrolysis with oxygen, both causes a gas which with electrocautery spark causes bubble blast. So what are the signs you see? Mainly sudden pop sound, the bladder wall movement. If you're placing a hand on the bladder for a suprapubic pressure, you can feel the movement of the bladder wall on it. And also there's loss of vision with perforation. So how do we counter this? So mainly by you judiciously evacuate the bubbles in the bladder by taking the resectoscope into the air bubble and remove the working element so that the bubbles come out. Then make sure you use continuous irrigation. Also, whenever you use a helic, try to fill the brim till the brim, and then give a helic wash so that the air bubbles doesn't go in. And also, sometimes Trendelenburg position helps the bubble to move so that you can do a dome resection and also a suprapubic pressure. So these are my take-home messages. Thank you.
Nice presentation, Deepak.
Yes, sir.
The paper is open for discussion. Any questions? Deepak, any situation where you have felt that it is not accessible by your regular resectoscope instruments?
Yes, sir.
What is your this thing?
Yes, sir. When
Any
there's
places in the bladder where you can't reach with your regular instruments? Have you faced any situation like that?
Dome tumors, sometimes in the dome, very difficult to access it. You may have to sometimes once what happened, we asked the other surgeon to give a pressure and I resected because the pressure was not sufficient to press the bladder to reach the resectoscope loop. And also when there is a high bladder neck or a patient who has very short stature with a suspensory ligament are so strong, the resectoscope doesn't reach. Sometimes it's got bent as well. So these are the situations. So in a high bladder neck, we resect the bladder neck and then go ahead with TURBT. Dome tumors, try to give as much pressure as possible, get the tumor down and try to resect. Otherwise, with patients who have very short stature and taut suspensory ligament, I'm not sure, sir. I have not faced that.
Yeah, so a couple of points that I wanted to just add. So this is a regular challenge. It is not like it's a rare challenge. So two strategies that we have started using routinely. One is we do a perineal ureterostomy. We do a perineal ureterostomy. So our scope, we circumvent about 7 to 8 centimeters, sometimes even 10 centimeters of the scope length outside the body. So we reach the tumors very easily and then we can resect. This is one thing that we have done. Not in many cases. I think only 3 cases we have done till now. The second thing is you can consider doing a laser TURBT.
Yeah,
so the laser
next question was that what's your
No, the we are only opening the urethra.
There is a long resectoscope by stores. Why not use that?
No, it's not easily available. We have checked.
Oh, okay. I use it. I have it.
Must be a long time. No, you can do with some minimal bladder filling, sir. You with half bladder or minimal bladder filling with suprapubic pressure, slowly and steadily you can get the tumor out. It's not like that. Majority of times you can come out. Perineal ureterostomy is a good option, but patient accept and then those things can be challenged.
No, we can. What we have done is we have closed it, put a catheter, and let it heal. And
yeah, one more option is laser N-block resection. Or even with N-block.
No, since we have got many uro-oncologists here, do they agree with laser, sir?
Yeah, it is very good. You get N-block.
No, N-block is okay, but what about the deeper tissue?
Yeah, you can completely even get the muscle. Whichever I submitted by doing N-block resection.
I think TURB with some kind of adjustment with the loop
yeah.
is the only way. Laser, we have tried it. I've been doing a lot of N-block. In the dome, inaccessible side, it's very difficult. You would do half of it and it will start hanging. You cannot get into the other part of it. If at all, if inaccessible TURBT, I think bipolar loop, slight adjustment with the loop itself is a possibility to do it because you can make it straight also. Sometimes you can make the loop straight and you can. Yeah, that's what. But laser is difficult. It doesn't have a control at all.
No. I'm not telling about dome. See,
yeah, lateral wall is fine. Lateral wall, the best thing is to do with the laser.
My dome tumor. What I do, I use this mushroom button electrode.
Okay.
And nicely I can completely sweep it up. And N-block, almost N-block only we remove. I remove. That's what I. Yeah, dome. You saw no that Gangadhara Murthy, huge tumor, full. And N-block I think still is a good technique.
Option.
You definitely get the muscle in that. Okay. Yes. So tumor near the orifice, I think en bloc resection with
Is
laser
better.
is the best. You will not injure the ureter much.
Thank you, sir.
Yeah.
We request
Thank
the
you. Thank you,
chairperson
Deepak.
to hand over the memento to the speaker. Accurate pathology remains central to bladder cancer management. To discuss the key updates in bladder cancer pathology, we invite Dr. Divya V, Senior Consultant Histopathology, Sri Shankara Cancer Hospital, Bangalore.
Good afternoon, everybody. I'm here to talk about the essential updates in bladder cancer pathology. At the outset, I would like to thank Dr. Srivatsa sir and his team for giving me this opportunity. So as pathologists, as uropathologists, we are guided by different bodies. We have the ISUP, the GUPS, and several different bodies giving us guidelines, and it makes us very confused because they are not at consensus most of the times. So our Bible, however, is the WHO 5th edition of tumors of urinary and male genital tract. So Globocan 2022 has reported 6 lakh new cases every year, and it stands, bladder cancer stands ranks 9th in terms of incidence and 13th in terms of mortality. And WHO has predicted doubling of bladder cancer by 2040. Now, of all bladder cancer cases, majority are urothelial carcinomas, of which 70% are non-muscle invasive and 30% are muscle invasive bladder cancers. Once these tumors arise from precancerous lesions, they progress along 2 pathways, the papillary and the non-papillary pathways, which are 2 distinct clinical diseases. Now, today I would like to outline the key updates in grading, staging, molecular taxonomy, and the emerging biomarkers for personalized treatment. Now, historically, WHO in 1973 came up with the 3-tier grading system for bladder cancer, which has progressively evolved into the 2-tier grading system, which was adopted in 2004, and we still follow this now. But there are significant problems because of subjectivity and prognostic variability, especially for non-muscle invasive bladder cancers. Now it has gone around one full circle, and the ISUP very recently in 2026 has come up with this 3-tier grading system again, where low grade remains low grade G1 and high grade is split into G1 and G2. This is to improve prognostic stratification and inter-observer variability. Now, it is not that simple. What appears as a low-grade tumor might show focal high-grade areas as seen here. So what do we do in such cases? So this kind of heterogeneity occurs in 1/3 of papillary urothelial carcinoma cases. So for this, the Genitourinary Pathology Society has come up with a recommendation that in a predominantly low-grade tumor, non-invasive, if there are focal high-grade areas accounting to less than 10%, please report it as non-invasive low-grade papillary urothelial carcinoma with less than 10% high-grade component, and add a note that there is limited data about this minor high-grade component, and they may behave more like low-grade tumors rather than high-grade tumors. Coming to staging, we know that in any TURBT, it is the muscularis propria invasion which is the most important element which is to be reported. PT1 is lamina propria invasion. Now there is a lot of recommendation about substaging PT1 into PT1A and PT1B. PT1A is lamina propria above muscularis mucosa, PT1B is muscularis mucosa and deeper. So this has significant prognostic progression risk. PT1B has higher progression risk as compared to PT1A, and ISUP has recommended the use of micrometric methods. This can be done on digital pathology slides. So there are 2 main expressions of urothelial carcinoma. One is the low grade papillary, the high grade, which may be papillary or non-papillary. And low grade papillary is prognostically favorable and has stable molecular genetics, usually the FGFR3 alterations. Whereas the high grade tumors have TP53 mutations and they're genomically unstable. This brings us to the molecular classification of muscle invasive bladder carcinomas. It started with the University of North Carolina classification 2014, where they simply divided urothelial carcinoma into basal and the luminal types. After that, there were several molecular classification systems. The landmark one was the TCGA of 2017. Now, right now, we usually follow the international consensus classification of 2020, where there are 6 groups. Now, why are there so many classification systems? This is because they lacked correlation with one another. Hence, clinical implementation was very difficult. And these systems could not be easily brought to routine practice because the technology involved was very complex and expensive. And a significant limitation is the use of frozen repository tissue where the pathologist could not screen the material. So this is the most internationally accepted classification which came in 2020. There are 6 groups. 3 are luminal and 3 are non-luminal. The luminal papillary shows the FGFR3 signature and has favorable prognosis. Luminal non-specified shows a stromal signature and has intermediate features. Luminal unstable is highly aggressive, shows P53 mutations. The stroma rich shows stromal markers. Basal squamous shows EGFR, TP53 and RB1 mutations. The neuroendocrine-like expresses neuroendocrine markers and shows P53 and RB mutations. Now, because the testing systems are very complex, IHC has been investigated as a surrogate marker for these molecular subtypes. And Lopez, Beltran and Cheng have proposed these 3 groups based on IHC. So, luminal subtype, which shows the urothelial markers GATA3 and CK20. Then there's the basal type, which shows CK5 and 14 expression. And the double negative type, which is negative for all these markers. And IHC is always limited by heterogeneity and the quality of the tissue available. Can we bridge the gap between histomorphology and the molecular taxonomy? To some extent, yes. So we know urothelial carcinoma shows divergent differentiation in the form of squamous, glandular or small cell differentiation. It is seen that the squamous histology correlates with basal type, EGFR expression. Glandular is luminal. Small cell neuroendocrine expresses neuroendocrine markers and is usually double negative. There are few aggressive subtypes of bladder urothelial carcinoma. The micropapillary one is luminal and shows HER2 amplification. The nested type shows TERT promoter mutations. The plasmacytoid shows loss of CDH1 or E-cadherin. And the sarcomatoid type shows high P53 mutation, high mutational load, high TILS and PDL1 expression. Now, each of these molecular subtypes has significant clinical implications. So, for example, the lowest risk is the luminal papillary type, which responds to FGFR3 inhibitors. The luminal non-specified, the luminal unstable, and especially the stroma-rich ones, they respond to immune checkpoint inhibitors. The basal squamous types also show EGFR expression and they may respond to EGFR inhibitors. The neuroendocrine-like, they show response to immune checkpoint inhibitors and combined chemotherapy. Now again, as I discussed in grading, it is not simple because molecular heterogeneity is a known factor. As the tumor involves, genetically distinct clones arise through natural evolution or because of clonal selection following chemotherapy exposure. Now this is associated with tumor progression and relapse after treatment. So a challenge is in identifying these potentially lethal clones which may be intrinsically resistant to therapy. An example is a low-grade FGFR mutant luminal type tumor might harbor subpopulations of P53 mutant basal type high-grade urothelial carcinoma. Now coming to the molecular biomarkers which can be used in clinical practice, the most commonly used biomarkers is the PDL1 which is used across tumor types. PDL1 assessment by IHC guides immunotherapy selection. Now PDL1, so there are several clones of PDL1. This comes with the concept of companion diagnostics, where a particular PDL1 clone, the DACO22C3 for example, determines response to a particular drug, which is pembrolizumab. This is run on a particular platform and has cutoff values which is predetermined. For example, more than 10% CPS determines response to pembrolizumab in bladder cancer. The MSI unstable tumors show good response to immune checkpoint inhibitors. HER2 testing, which can be done by IHC and or FISH, this determines response to trastuzumab and other HER2 antagonists. However, there are no standardized criteria right now for HER2 evaluation in urothelial carcinoma. FGFR3 testing by PCR is required for treatment with eldafitinib, which is an FDA-approved drug for bladder cancer. Nectin-4 and TROP2 can be targeted. However, testing is not recommended for these two biomarkers. Now, there are biomarkers which correlate with cisplatin sensitivity as well as resistance. For example, the 3 gene signature, ATM, RB, and FANC, they comprise a DNA repair-related gene signature which correlates with cisplatin sensitivity. ERK2 mutations also show complete response to neoadjuvant chemotherapy. There are several other molecular abnormalities like ERK1 and PARP1 which show resistance to cisplatin. Now, there's an emerging role of liquid biopsy in bladder cancer management as in other cancer types. So, this involves quantification of circulating tumor cells and the urine tumor DNA as well. So, these are malignant cells which are derived from the primary tumor which can be detected in the blood. So, high CTC levels may indicate persistent or recurrent disease, and high CTC is generally seen in muscle invasive bladder cancer cases. The plasma cell-free DNA analysis can also be done. However, the technology involved is quite challenging. Now, urine tumor DNA estimation can be done. It is also a biomarker. UROSeq platform is the first non-invasive urine-based NGS screening, which was developed by the Johns Hopkins University, and it is used for disease detection and monitoring. It detects tumor recurrences with 80% specificity and 68% sensitivity. Minimal residual disease testing by urine tumor DNA test is also in research right now. It is found to be superior to blood test, radiology, or even biopsy, especially when cancer is not clinically detectable. So, directions for research: the application of AI in digital pathology. It can be applied for standardized grading as well as for prediction of biomarker expression based on the HND slides. Integration of molecular and morphological classification would help in clinical decision making, and validation of novel biomarkers. There's always a race for this. So, my conclusions are: personalized treatment based on molecular classification, biomarker development would help in management of metastatic bladder cancer. The ISUP grading system will soon come into practice. There is heterogeneity both at the morphological and the molecular level. This presents a challenge as well as an opportunity for treatment. Integration of molecular and morphological data and pathology reports would help in clinical decision making. And ongoing development and validation of newer targets presents a rapidly expanding area where pathologists will play a role in patient care. So my responses.
Thank you, ma'am.
Happy to take questions.
One thing is, do you recommend this IHC and this molecular markers for every patient, or is there any subset patient which you recommend this IHC or this molecular marker testing?
So we would recommend testing for all cases, because unless we test, we are not going to know what is the expression pattern and how they are going to behave.
Do you routinely give in your center that all patients this
No,
IHC?
it is not in practice.
How costly
right
is
now.
it, madam?
Sir, IHC panel will at the most cost for a few markers would cost 7,000 to 8,000, but the molecular tests are going to be expensive. But unless we do the testing and molecular, we are not going to know. All our reports will look similar. Invasive urothelial carcinoma of one patient is not going to behave similar to a invasive urothelial carcinoma of the same grade in another patient.
Since we have got a lot of uro-oncologists here, what is your experience, sir, with this? Do you routinely ask for these markers or what, sir?
From last 3-4 months, we routinely do IHC for all cases.
Okay, madam. Thank you. One more thing. Do you want any message to be given to the surgeons regarding the specimen what they send?
I think right now we are happy with the specimens we are receiving.
Because most of the pathologists will not be happy with the specimen what we send. So do you want to really give any message?
Fixation. The tissue we are getting is adequate, especially for small biopsy specimens. Again, we would like to receive specimens early, and the common message is that all specimens should be immediately put in formalin and sent to the lab as soon as possible. And please do not try to cut or distort the specimen because later reporting becomes very difficult.
Last question, I know we are running out of time. Do you want us to send because that's been the practice of resecting tumors and sending the superficial tumor separately and the base separately. Does it make a difference, or you are happy to just collect it?
It makes a difference, sir. If we get the muscle part separately, it is very easy to assess. Otherwise, we'll have to look for and search for the muscle tissue among the tumor fragments, and that might be difficult.
Thank you, madam. Thank you.
Thank you, ma'am. We request the chairperson to hand over a token of appreciation to Dr. Divya. We request Dr. Amrutraj Gowda to hand over that token of appreciation to the chairperson. Moving on to the next session, which is chaired by Dr. Nagar Subramaniam S., Senior Consultant Urologist, Manipal Hospital, Bangalore, and Dr. Giridhar Venkatesh, Senior Consultant Urologist, Manipal Hospital, Bangalore. We request you to come to the dais. Bladder cancer management increasingly relies on integrating histology, imaging, and molecular markers. To discuss this multimodality risk stratification approach, we invite Dr. Ravichandran, Consultant Urologist, Sparsh Hospital, Bangalore. Over to you, sir.
Good afternoon, everyone. It's a post-lunch session. Intense topic, multimodal risk stratification in bladder cancer, integrating histology, IHC, clinical, imaging, and molecular parameters. A bit of my presentation has already been dealt by Divya ma'am before, but I'll be skimming through those topics as well. First, let's set the context. We've been hearing since morning that our uro-oncology tumors are very heterogeneous, starting from prostate and with bladder. And of the two, I would say bladder takes the lead. It is so heterogeneous, it's like our panel members. So many subtypes, so many variants, no two have the same opinion and no two act the same, no two agree with the same. So bladder cancer is something like that, very, very heterogeneous biological behavior. And we all know that historically, we've been relied more on stage and grading for risk stratifying the bladder cancers. But then of late, with advent of better imaging technique, better molecular understanding, a better understanding of the biology of the tumor, there has been increasing role of molecular and imaging biomarkers as well. And precision oncology would require assimilation of all these pathological, imaging, and molecular, a multimodal integration for better delivery of treatment for these complex heterogeneous bladder cancers. Before we move on, let's look at the evolution of this risk stratification as where we've started, where are we today, and where are we heading in future. Early era, it was all about stage and grade. The risk stratification was purely on pathological staging and the age-old, 5-decade-old 1973 WHO classification of G1, G2, and G3, wherein if pathologist is not in mood, the report would be G2. You're neither there at G1 nor at G3. But then subsequently, things evolved, a better understanding of biology, and with the new molecules coming into picture of intravesical therapy, with BCG coming into picture, then people realized that it's just not stage and grade, it's also about the exposure of the medication that the bladder cancer is having, and also more role of the clinical parameters like tumor size, tumor multiplicity, prior recurrence rate, and whether carcinoma in situ, if it adds a new dimension into the risk stratification or not. So in that regard, we had EORTC. This was in pre-BCG era, EORTC. Subsequently, Kyoto came up saying that in post-BCG exposure, things are totally different, and then we had a totally new risk stratification. Subsequently, currently, we've been using EAU and AUA, wherein there are a little more pathological refinement, and we use the latest WHO classification, wherein there is no ambiguity of G1, G2, or G3. It's pure low grade or high grade. The pathologist has to commit if it's a low grade or a high grade, so that the observer variability is better and the clinical application is also better. Along with that, few additional risk factors came into picture, like in lymphovascular invasion, variant histology, and depth of T1 invasion, so on and so forth. So now at present, we've all been using EAU and AUA. For me, EAU is my personal favorite, easy to use. There is an online tool, you put up the variants and it just shows up whether it's a low risk, intermediate, high, or very high risk. And depending on this risk stratification, the treatment is completely different. This bladder cancer is so heterogeneous. A couple of micron of extra invasion of lamina propria, you're there into the muscle. And then the treatment gamut is completely different. The intravesical therapy does not apply. You need to go more aggressive. So then the question raised saying, are we okay with purely these clinical and pathological parameters to determine if the risk stratification is good enough to decide the subsequent treatment line? And then this MRI came into picture, wherein just presence or absence of tumor is not enough. We need to get more information out of imaging. And then came the VIRATS, something similar to PIRATS, which we've all heard in the morning. So it's a new MP-MRI scoring system, which was developed in 2018 to standardize the imaging and reporting of MRI of the bladder. Basically, it's T2 imaging, diffusion weight imaging, and dynamic contrast. These three phases has to be there. And then similar to PIRATS, it's score of 1 to 5. Score of 4 and 5 are highly likely of infiltrating the muscle wall, essentially T2 disease. And there have been meta-analysis to prove that their sensitivity and specificity is pretty good. And also the multi-institutional multi-reader also shows that AUC, area under curve of 0.87, is good enough for stratifying whether it is muscle invasive or non-muscle invasive. It came in 2018. Subsequently, we had a COVID outbreak. And then in a sense of having this TURBT-free pathway, the VIRATS took up a good pace. People were like, we will do an MRI. If MRI is showing muscle is invasive, why are we bothered doing a TURBT? Why do we bother admitting the patient, do a TURBT, additional admission, additional risk of COVID exposure? So during COVID, there was little fast tracking of these pathway. However, on day-to-day basis, it has not been adapted so well as what it was predicted to be. Next. The VIRATS didn't just stop at differentiating between risk stratifying between muscle invasive and non-muscle invasive. They went a step ahead and they thought, in post-neoadjuvant chemotherapy patients, let's do an MRI, let's do a VIRAT scoring and see whether they have responded well to neoadjuvant chemotherapy or not. And in those studies, there has been good correlation between this VIRAT scoring and complete pathological response post-neoadjuvant chemotherapy. So on and so forth, there has been amazing experimentation in terms of radiological risk stratification parameters, and an MRI seems to be very promising in that regard. Not just MRI, even PET-CT has been used for risk stratifying, and a higher FTG uptake is associated with elevated PD-1 and PD-L1 expressions. And in a retrospective analysis, a SUV max was significantly associated with both PD-1 and PD-L1 expressions, and an XUV cutoff value of 22.7. At the cutoff of 22.7, PD-1 and PD-L1 status predicted with accuracy of 71 and 77%. That's a very good number. It's essentially like you are bypassing the role of molecular. You're directly looking at imaging. You're directly looking at radiomic factors to see how these patients are behaving. And similarly, FTG PET-CT also has a role in post-neoadjuvant chemotherapy settings as well. So this is where we are currently at, looking at MRI, looking at VIRATs, looking at FTG PET-CT to see whether they are good enough to risk stratify between non-muscle invasive and muscle invasive. Where are we heading next? Now, deep learning based MRI reconstruction using neural networks are coming into picture. Maybe a matter of time, you get an MRI done and then you have a report in hand saying whether it is going to be a muscle invasive, non-muscle invasive, whether they're going to respond to BCG or not. If it's a muscle invasive, whether they're going to respond to neoadjuvant chemotherapy or not. So there is unlimited role for AI and radiomic and metabolomic together. And also, VIRATs-based risk stratification tools are still at experimentation level. Probably once we make a good stride here, they'll all be easily adopted for day-to-day clinical practice. So with this, we wind up with regard to imaging radiomics. Let's head out to molecular classification. This molecular classification is not something which has been evolving in last couple of years. It has been there since almost 2 decades. But then in 2014, with the Cancer Genome Atlas, that's like a tipping point. That's where the page got turned with amount of data that we got in regard to bladder cancer. Subsequent studies have used that data. And currently, as Divya ma'am mentioned, we are currently at a phase where we are differentiating them broadly into luminal and basal. Ma'am has already touched upon it, but I'll just touch on a couple of factors which is important for us as a clinicians. As she has already mentioned, there are 2 important types, luminal and basal. And in luminal papillary, luminal infiltrated, and luminal non-specified. To make it simple, luminal papillary is a good one. It's a low risk one. Whenever FGR3 mutation is there, it essentially means they are low aggressive, not so bad. It is okay. Luminal infiltrated is where the P53 wild type is involved. Can you get a laser, please? Pointer. Henge, ida. So whenever FGR3 mutant is involved in luminal papillary, they are good. The moment P53 wild type, anywhere you see a P53 wild type, it means it's an aggressive variant. For FGRT mutant, the FGRT inhibitors are good enough, like adafitinib. For in the luminal infiltrated variant, we need to look at immunotherapy, and these patients respond poorly for our conventional chemotherapy. Luminal non-specified is somewhere in between the two. We have these uroplakin, KRT, so on and so forth, but then we are yet to develop targeted therapies for these types. Basal is aggressive. They are very aggressive. The risk of squamous differentiation is high, and these also would require immunotherapy, and sometimes they do respond for better. They respond better for chemotherapy. And we all know any neuronal, any neuroendocrine differentiation, it's a bad prognosis. So if there is any take-home message for today's presentation for postgraduates, this is the slide. This is what is going to dictate probably next decade of our bladder cancer management, understanding of whether it is luminal or basal, and the variants and how it has a therapeutic implication. Ma'am has already touched upon these molecular subtyping is very expensive, not for our Indian patients. So probably IHC is a very good surrogate for that. So whenever we have GATA3 and CK20, these are the luminal markers. The basal markers, remember, basal is aggressive, P53 is aggressive. So basal markers are CK56, CK14 and P53. And there are a couple of other IHCs with potential therapeutic targets. So IHC is a good surrogate for molecular subtyping. We can use IHC for day-to-day risk stratifying of our patients. Next, this is something new, CHAI. It's a new platform, AI-based platform, wherein the slides are digitized and then subjected for an AI software, wherein it is able to tell us exactly the relevant histomorphic features. It will look into the tumor cells, the nuclei shape, nuclei pleomorphisms, mitotic activity and cell organization, and it also looks at the tumor microenvironment. An AI, deep learning machine-based AI system is able to study the slides, is able to study all these relevant parameters, and it is able to tell us in these high-grade NMIBC whether they are going to recur post-BCG or not. And there has been comparison between EAU and AU risk stratification with that of this AI-based platform, and this AI-based platform seems to be functioning better than the conventional risk stratification tools that we are using. So take-home messages. Are we already there? Take-home message is, yes, bladder cancer is biologically very, very heterogeneous. For now, histology still remains foundational. Imaging and molecular data will refine this risk prediction for us. And the multimodal models, wherein the histology, IHC, radiomic, metabolomic together would enable a much better precision management for all our bladder cancer patients. Thank you.
Thank you very much.
I just wanted to ask you one question. Are there, right now, are there any models which integrate all the modalities that you just mentioned to get a better prediction of outcomes?
No, sir. We don't have all the models integrated together, but at different points of clinical decision making, for example, risk stratifying of NMIBC, non-muscle invasive, now we have EAU, low, intermediate, and high, and very high, very high. So to replace that, we have an individual imaging-based protocols, molecular subtyping for that, but an integration of imaging plus molecular, we are at to. That's a holy grail. Probably once we break it, it will be a
probably like
epic moment for us.
Thank you very much, sir, for that insightful talk. We request the chairpersons to hand over a token of appreciation to sir. While BCG remains a standard therapy, new strategies are emerging for patients who fail or cannot tolerate BCG. To discuss these evolving options, we invite Dr. Rahul Pradhan, Consultant Uro-Oncologist at Bagchi Sri Shankara Cancer Hospital, for his talk on Beyond Intravesical BCG Therapy. Over to you, sir.
Good afternoon, everyone. I'm Dr. Rahul Pradhan from Bagchi Sri Shankara Cancer Hospital, and I thank Dr. Srivatsa for giving me this opportunity. So I'll be talking on beyond BCG intravesical therapy, what options do we have? First is, why is it so important? We know the high risk of recurrence for urothelial cancers. If you put in your recurrence scores in your URTC for a 3 centimeter primary bladder tumor, it is almost 24% and 46% at 1 year and 5 years. And also the progression rates are there. And almost more than 50% of them will recur at certain point of time. And definitions of BCG failure I will not go into, just for a revision, also for the postgraduates, all this you should be knowing. Again, to define any kind of BCG failure, we should be sure that adequate BCG has been given. That is at least 5 or 6 of the induction, and at least 2 or 3 of the maintenance dose has to be given. Or if it is a reinduction, at least 5 or 6 doses of the initial induction and at least 2 of the 6 of the reinduction course has to be given to be called as adequate BCG. Now coming to the numbers, what is the response rate? If it works well, it works for around efficacy is around 70 to 80%, but failure rates are almost 33%. Huge dropout rate, 35 to 50%, and serious side effects of BCG toxicity and systemic BCG, which is around 1 to 5%. Now, once we fail BCG, so currently BCG is the best. What are the other options once we have a BCG failure or someone is unresponsive? Strong recommendation from the EAU is that offer radical cystectomy. Other than that, that is the most preferred options, and as per the NCCN, we have some other options which I'll be discussing in the subsequent slides. Should BCG be given a second chance? Yes, BCG reinduction should be given another chance for patients who can tolerate it. In certain cases, almost 89% there can be a complete response at 3 months and 65% at 6 months. 6 months, so 36 months, sorry. So what are the alternatives that we have? One is intravesical chemotherapy, device-assisted therapies, immunotherapy and target therapies, gene therapies, and vaccines. I will be discussing which are FDA approved, which are in trial phases, and which are available in India at the end. So first is intravesical chemotherapy. So as per the FDA approval, only currently, since age-old, only valrubicin is approved for intravesical therapy. Rest, all the others are still not yet approved. Gemcitabine, docetaxel, gemcitabine plus mitomycin, sequential gemdosi, or paclitaxel. None of them have received FDA approval till now. So the new kid in the town is the sequential gemcitabine docetaxel. It is very exciting that the results are very good, and it provides a 2-year recurrence-free survival of almost 82%. And this has started, why? Because there was an acute shortage of BCG a few years back, and people started exploring other options that had a better results. And this has come up a long way, that many of the centers are giving upfront BCG, especially now currently we're going through some centers are having an acute shortage of BCG again. Second is the device-assisted therapy, where intravesical delivery system of a sustained release gemcitabine, that is the TAR-200, where mitomycin is released constantly for a period of 20 days through a cystoscopy. We place the device in the bladder. And this was based out of the Sunrise 1 trial. Based out of that, in 2014, this has approved FDA approval. And complete response rates of 84%, 12 months complete response rate of 45%, and a cystectomy free rates at 24 months of 75%. Then chemohyperthermia or the HIVEC, which is a heated chemotherapy inside the bladder. Again, there are multiple trials for that. The 24 months recurrence-free survival is 78%, but there is still no long-term data. Radiofrequency induced chemotherapy. This is also another device assisted therapy where another device is instilled into the bladder and radiofrequency is administered. It improves the penetration of the drug into the epithelium. And again, we have electromotive intravesical therapy, where 2 electrodes are placed on the bladder, and due to the flow of the electric current, there is better penetration of the chemotherapy drug, that is mitomycin. Now, with the meta-analysis of all this, they have been shown to have a lower recurrence-free rate, lower recurrence-free survival, and lower incidence of side effects like fever. But there is still no long-term data and no RCTs basically on OS, PFS, and DFS. So these are the various devices that are available and which are recommended by EAU, is that the radiofrequency induced hyperthermia is chemotherapy is recommended by the EAU. Immunotherapy. So these two are approved. First, coming to a systemic pembrolizumab, which received approval in 2020 based out of the Keynote 057 trial, and it has a complete response of 41% at 3 months and sustained response lasting more than 1 year in 20% of the patients. And again, there is another trial, Keynote 676, which is looking at a combination of pembrolizumab and BCG in the intravesical therapy, which is still enrolling. Intravesical pembrolizumab, as I said, there are small trials. Phase 1 trial is going on, which is still promising results are seen. 67% recurrence at 6 months and 22% at 1 year. Then second is the intravesical NAI plus BCG, which is the trade name is called Anktiva. So this has received the FDA approval in CIS plus or minus a papillary tumor, where they have shown very good response rates of 84% at 36 months and a disease-specific survival of 99% of 36 months. In BCG unresponsive, it has not received FDA approval yet, but the response rates, the results are pretty good. Cystectomy free rate of 36 months at 82% and disease specific survival of 96% at 36 months. Coming to gene therapies, so nandofaragene firadenovec is FDA approved also. So this is an adenovirus with human interferon alpha 2 gene. This is instilled into the bladder, and what happens is there is a viral transduction into the bladder epithelium, and it leads to DNA synthesis that leads to INF expression. So based on a phase 3 trial, this has received the approval of FDA, where complete response rate at 3 months was 53% and almost half of the patients remained disease free at 1 year. Patients without CIS, there was 73% disease free at 3 months and 60% continued to be disease free at 1 year. And then there are various other clinical trials based out of Pseudomonas, based out of Streptococcus pyogenes, and recombinant adenovirus. The results, again, these are based out of small trials only, still phase 1. And then there is Rutivac also, which is a phase 1 trial. All these trials are going on. So after discussing all this, what in our day-to-day clinical practice, what we can do is at least adopt FDA approved agents. These are the FDA approved agents: pembrolizumab, nandofaragenic firadenovec, again not available. Then nagopendiken alpha and TR200. So to conclude, BCG is the best. There is currently no level 1 evidence for any alternative that is better than BCG. BCG failure, radical system is the first, cystectomy is the first choice. And in our clinical practice, what we can do is a BCG reinduction, a sequential gemdosi, or a systemic pembrol, which these three are available to us right now. And there are so many promising trials with good results. Hopefully some of them will be available in India very shortly.
Thank you, sir.
Yeah. One question I have these agents been tested only after BCG failure or unresponsiveness, or if the patient cannot tolerate BCG, or have they been used upfront as well?
Yes, many of them are upfront, especially the trial on the GEM sequential GEM-DOSI trial, that is on a BCG naive patients. The results are patients who have not received BCG.
So how are the results? Are the results equivalent, or?
So there is no RCT currently that compares results of this and that, but the whatever prospective data is available, the results are promising.
Okay. And then the other gene therapy, this nadofaragene and that IL-15 superagonist, nogapendekin.
Yes, sir.
So all these, are they available in
No, sir, not yet available.
Not yet. Okay.
And the Sunrise trial, Sunrise 1 trial was going on in a few centers in India. And I don't know exactly how many centers are still doing it. Sir. So Sunrise 1, Rajiv Gandhi, Tata Memorial.
Totally Sunrise 4 trials are there. Moonrise is also there. I think 2 and 4 were for muscle invasive disease. We were part of Sunrise 3 for non-muscle invasive disease, where we give Anktiva, that is nogapendekin in alpha inbacicept, along with 50 mg of intravesical BCG. That definitely gives superior results. It's FDA approved. Whereas this one, retrospective data is available comparing the BCG versus GEM-DOSI.
Yes, sir.
For all types of tumors, intermediate risk and high risk, the hazard ratio was 0.57. For high risk, it is 0.56. So some data is there.
Yes, sir.
And there is some BCG shortage now, right now. I think it's not available. It's not available. No, it is not.
So many centers are
it is not available.
telling currently not available.
Currently not available. There are 2 patients waiting. They don't have BCG.
Send them to Shankara.
Thank you, sir.
Thank
we
you.
request the chairperson to hand over the memento to Dr. Rahul. We request Dr. Srinathan to hand over the memento to the chairpersons. And now comes one of the most exciting segments on the afternoon. That's a debate. The topic is early cystectomy, sane or insane. For this, we invite Dr. Ravi B. Devakar, Senior Medical Oncologist, Sri Shankara Cancer Hospital, and Dr. Ratkal, CS, Senior Consultant Urologist, Rescue Urology Hospital, Bangalore. Arguing for cystectomy, we have Dr. Sanjay Sureka, Professor in Urology, SGPJ, Lucknow, who will be joining via Zoom. And arguing against, we have Dr. Vivek Venkatramani, Leelavati Hospital, Mumbai. Over to you, sir.
I hope I am audible.
Yes, sir.
Yeah. Should I start?
Yeah, please start.
Yeah, greetings from the city of Nawab Lucknow. At the outset, I extend my apology for not being present physically. And thank you, Shankara Institute and Shivas for giving me the opportunity to present it online. So today I am going to talk about in favor of early cystectomy vis-a-vis bladder preservation. I think Dr. Vivek will talk about this bladder preservation. I had a great regard for Dr. Vivek for being a wonderful uro-oncology surgeon, but I don't know when he become a little more conservative. Anyway, so urologists love bladder, but we spend our career trying to preserve it. But sometimes our enthusiasm for bladder preservation may come at the cost of oncological safety. which is exactly true in cases of NIN, non-muscle invasive high-risk bladder cancer. Recurrence keep on chasing you, and often the patient and the doctors remain in false reassurance. Ultimately, sometimes the atom bomb can attack you. So why is the debate? The high risk, this is the highest, this is high risk disease, but it is still the non-muscle invasive bladder cancer. At the same time, we need to understand that all non-muscle invasive high risk bladder cancer is not the same. We have many treatment options which include the intravesical BCG, intravesical gemcitabine. At the same time, the more radical approach like cystectomy seems to be more life-changing experience for the patient. However, it is important to understand whether the quality of life is important or the life is important. So though bladder preservation looks attractive, but the real question is, are we preserving the bladder or are we preserving the cancer? So in high-risk NMIBC, the biggest mistake is not performing the cystectomy. I think audience are the same page that the biggest mistake is performing it too late. So high-risk NMIBC is a wolf in a sheep cloth. So there are multiple different categorization has been used in various guidelines. The commonly used guidelines we use is European Urology Association, who subcategorize high risk into very high risk as well. However, in AUA guidelines we have only high risk. So there are many different varieties of high risk, but the most important one, which we will focus on this debate, is high-grade THP with risk factors like large, recurrent, multifocal or elderly patients, any CIS, T1 high-grade with or without CIS, LBI, variant histology and disease failure. So there are various treatment options for high risk or very high risk NMIBC, which include first we do TURBT, then followed by intravesical therapy when it fails. We do delayed cystectomy or treat them finally as a metastatic bladder cancer in 30 to 50% of the patients. They ultimately fail the conservative or bladder preserving protocol. And other option is timely cystectomy, and I think this is the final best option which makes the game easy for you and patient. You have to understand that what are the challenges in this high risk NMIBC. High risk is mostly, we'll talk about the T1 disease and beyond T1. If we see the evidence that 30 to 50% of these patients harbor muscle invasive bladder cancer, or they tend to upstage in TURBT or in the subsequent follow-up. And 10 to 18% they harbor nodal metastasis. Why it is so? Because sometimes there are suboptimal TURBT, tumor heterogeneity, and the aggressive biology. Sometimes we call it NMIBC, is actually simply waiting for muscle invasive to be discovered. The other issues are the false comfort of BCG. BCG, of course, is effective and one of the gold standards for managing the non-muscle invasive bladder cancer high. But this is not a very reliable always and unpredictable. In fact, the initial response we used to get is 60 to 70%, but over the long time, the failure rate is from 30 to 50% in various studies. The BCG failure leads to higher risk of progression and higher metastatic risk. BCG works well until it suddenly does not. Other issues like BCG is effective, it looks attractive, but it is sometimes very toxic. In our experience, the local adverse effect is tune of up to 70%. There are patients who have systemic adverse effect as well. We have patients, I think 5 patients I have seen with a small capacity bladder post BCG, and of late I don't know because of change in strain, this is more common nowadays. And compliance to maintenance therapy is again a challenge. And in 80 milligram dose, in our experience, only 30 to 50%, and if you see the evidence, up to 70% patients only remain compliant to the maintenance therapy. Of course, as it was discussed in the previous talk, the disease shortage is a global issue. So the therapy we use for preserve the bladder itself is not without significant morbidity. We have other armamentarium like gemcitabine, prostatectomy, sequential therapy, With the best evidence, the recurrence-free survival is 60 to 70% at 1 year, which is not, of course, better than BCG, but it is useful when BCG is not available or in cases of BCG unresponsive NMIBC. But if you see the literature, the durable rate is only 19% in case of BCG unresponsive disease. So BCG and intravesical chemotherapy is only an option with lots of limitations. Early cystectomy, which I refer to as timely cystectomy, the 5 years disease survival is 80 to 90%. Late cystectomy after progression, it falls down to 50%. If we see the MD Anderson data, it also favors early cystectomy. The timing of cystectomy is extremely influenced on oncological outcome. If we see this literature, we can clearly see that there is a huge difference if we do early cystectomy in BCG unresponsive disease and it improves the outcome. Similarly, upfront cystectomy in other stages also shows that the survival advantage, there is definitive survival advantage in the tune of 20-30%. So there is no doubt that early cystectomy is favored in many situations of non-muscle invasive high-risk bladder cancer. The cost of delay, if delayed cystectomy after progression, as we've seen that it reduces the survival of cancer-specific survival. So bladder cancer time is not neutral, time favors the tumor. Prognosis of high-risk NMIBC with progression. If it progresses, so Vivek can be improved. Survival after progression in NMIBC is when it becomes muscle invasive is only 35%, 35 to 40%. So there are other area where this early cystectomy is also helpful, like in T1, TA, large bladder tumor. We keep on trying multi-stage TURBT open, and ultimately patient come back with a residual tumor or recurrence. So it's a one-time treatment, and it's very useful in many patients, even in TA high-grade tumor. So who truly needs early cystectomy? It is not that bladder preservation is completely outdated, but the guidelines strongly support that BCG unresponsive disease, high-grade disease with concomitant CIS, variant histology, intravascular invasion, persistent T1 or on weak UROVERSE, these patients' bladder preservation mostly compromise the cure. There are lots of resource utilization issues. Patient needs cystoscopic surveillance, maintenance therapy, imaging studies, potential service therapy. So if we go for early cystectomy, it's cost saving for the both healthcare system and for the patient. Other issues like it's a one-time procedure. If we talk about the quality of life and the outcome of early cystectomy, after understanding the enhanced surgical recovery, and we have many better tools, the outcomes are really excellent. We can see the in robotic radical cystectomy, nicely Neo-bladder and patients are fully contained. Our patients often they don't require any CIC after radical cystectomy. So to conclude with cure first, bladder is second. The bladder can be reconstructed, but survival cannot. In high-risk NMIBC, early cystectomy is not the offer treatment, it is timely cure. I am happy for my patients as my patients are happy with early cystectomy. I know the debate is a little upset, but it's fine. Thank you.
Thank you, Sanjay. Dr. Vivek.
Thanks, Sanjay, for a great talk. You've almost convinced me. So let's see if I can convince you the other way. Can we have the slides?
I'm already convinced.
So I'm going to tell you why early cystectomy is truly insane based on just 4 points. And I think a lot of it was covered by Rahul also in his talk. Debate. Yeah. Thank you. So, as Sanjay was saying, cystectomy, which is done in a very high-risk NMIBC or in BCG unresponsive disease, that's what we are debating. And these are the points that we'll show that why it is not a great idea. So BCG, first point, is actually extremely effective. It has reduced cystectomy rates from 55% to 11% in cases of CIS. And if any chemotherapy agent had this kind of response, it would be on the front page of practically every newspaper. 30% are even durable beyond 10 years. If you see the risk of progression, Dr. Kamat's slide, it does reduce the risk of progression significantly, and the higher you go in terms of risk categories, it's actually a more pronounced effect on the risk of progression. So there's a significant reduction in recurrence as well as progression, and 27% patients are actually alive with an intact functioning bladder even 10 to 15 years after diagnosis. Can we remove that thing, the last line? I would argue that removing even 1% of bladders unnecessarily is probably too much. Okay. Then, second, can we improve on BCG? BCG has good results, but we are even getting better results now. Dr. Rahul touched on this, the GEM-DOSI trial. 2-year cancer-specific survival, 100%. 2-year recurrence-free survival, 82%. And everybody practically kept their bladders. So it's excellent efficacy. And for those who complain about the toxicity of BCG, you've got a good alternative with reduced toxicity and probably even better efficacy, which was shown in one retrospective cohort where the high-grade relapse-free survival at 2 years was actually better with GEM-DOSI than BCG. So the final outcome will be... Kya kar raha hai? I'm not able to move it. Okay. So the final outcome will probably be shown to us by the bridge trial, which compares them directly, but we do have good alternatives. Sir was asking about use of newer agents in BCG naive disease. This is the QUILT trial, phase 2 interim results just last week, or last month actually. 85% complete response at 6 to 9 months. Versus BCG alone, it was significantly better. So we are getting better with our intravesical therapy, even in the BCG naive setting, and there are a number of trials underway to even test this hypothesis further. So the further we go, I think we'll have even better alternatives. Third, what are the options we have in unresponsive disease? Again, I think Rahul did this, touched on this. It's a BCG unresponsive with sequential GEM-DOSI as a rescue. Cystectomy free, 5 years, 75%, long-term outcomes. Cancer-specific survival, 91%, probably as good as the early cystectomy numbers which he was quoting. So we have alternatives which are excellent and which have long-term survival. Again, Pembro, not very impressive in comparison to that. It's a 46% complete response, was durable more than 12 months. Again, Nadafarogene, already covered. Again, complete response of about 50%, which was maintained at 1 year. This is the new kid, which will probably change things. Anktiva, again, the same IL-15 superagonist. 82 to 84% avoided a cystectomy at 36 months. So now we are not talking only 1 year or 1.5 years. We're talking 3 to 5 years. 71% showed complete response with durations more than 53 months. So these are things which are definitely changing the game in favor of bladder preservation. We have newer things. I missed out the TAR 2110 trial. It's just there down. And the oral erdafitinib as well as intravesical can be given. And there are numerous other things which are under study. So we have good options in BCG unresponsive disease. And so in fact, IBCG has shown that these are good options before you can even think about a so-called early or timely cystectomy. So you can consider all these second options. Finally, the elephant in the room, early cystectomy. So we know it provides a good pathologic staging. There may be upgrading, upstaging. It has a good long-term DFS, but now we see GEM-DOSI and other molecules are reaching the similar disease-free survival and cancer-specific survival. But what are the problems? Mortality 2.1 to 3.2% at 30 days, up to 8% at 90 days. And this is in the best hands, maybe Dr. Sanjay's hands, but not over the whole country of India, where we are mostly doing cystectomies in low volume centers. So things are probably worse. And contrary to what he would like you to believe, the morbidity of a cystectomy is not lower if you're doing it in NMIBC patients. It's actually the same whether the stage is T2, T3, T1. So you're not reducing the morbidity by doing it earlier. However toxic Moscow might be, it's nowhere related to the toxicity of a radical cystectomy. Finally, patient acceptability. There is a desire, of course, for bladder preservation and avoiding overtreatment or the morbidity of surgery. And it's not that we are losing our window for cure. If you do a cystectomy within 18 months, you're not losing out any cancer-specific survival, and there is a window to proceed with rescue therapy without risking the patient's life. So there is an alternative, choose it. Finally, looking to the future, bit of a googly here. Niagara and EV Pembro have shown complete response rates in MIBC of 50% plus. Patients are refusing to have a cystectomy in MIBC, and we are debating about NMIBC. This was Dr. Tom Paul's yesterday's EAU saying many patients want to keep their bladders in MIBC. So where are we talking? Is cystectomy in 5 years even going to be done for MIBC? Another question. And the way we see therapies moving from later lines to earlier lines, it's only a question of time before our things improve in NMIBC as well. So to conclude, GEM-DOSI is very effective. BCG is very effective, and we are beginning to improve on it. Many approved second-line therapies now are available in unresponsive disease. They have good long-term outcomes and show cystectomy-free rates, which are quite high. However great a surgeon Sanjay might be, he cannot compete with God's creation. Finally, we have an 18-month window for a rescue therapy without compromising oncologic outcomes. So with newer drugs, we are probably heading to a cystectomy-free world. So your days are numbered. Thank you.
Sanjay? Sanjay, can you hear us?
Yes, sir.
Any rebuttal?
Yeah, I have just 2 slides for it.
Good.
So though it is, am I audible?
Yes, sir. Yes, please.
Yeah, so though it is a harsh reality, but BCG failure is common, as you all know, and the shortage has made it more difficult. So 30 to 50% patient fails in BCG and may progress despite of adequate therapy. And we all understand that the compliance for maintenance BCG, which is a very important aspect of BCG therapy, is very poor in our setup at adequate dose. And disease is often understressed, and delayed cystectomy worsens the survival. There is no doubt about it, whatever Vivek tried to justify. So bladder preservation is appalling, but when it fails, there may be a really more painful for the patient, and we often lose the purity window. So it's fine, you can preserve the bladder. Vivek may be happy with it. He loves bladder, being a urologist. But I am happy for roaming without my patient roaming without a bladder, and when they are disease free. Thank you.
Yes, Vivek? Nothing. I am for early cystectomy. Because, Sanjay, I am with you.
Thank you, sir. Thank you so much.
Because we have to.
Vivek is also for.
No. I'll take the voting. So, because first thing we should understand is biological behavior of the tumor. And with all that circus, finally you may have to do cystectomy, at least few percent of cases. You lose the window of opportunity, that golden period, where you can almost give cure. I agree.
So you won't lose it if you're giving another treatment.
Yeah.
If you're doing nothing, you'll lose the window
you are
of cure.
giving, but still you are not 100% sure. Yes. But quality of life is very important, but life is more precious. But adding this Neo-bladder, you are definitely giving a better quality of life. If your selection of the case is very,
I would
very good.
disagree with that, sir. Neo-bladder has not proven any study to have a better quality of life.
Definitely, compared to Ileal, Conduit and other things, it gives definitely better results. Because we have in our experience, we have done some Neo-bladders, they are still doing very well. That's why on those experience only I am touching. Now, vote from the house. How many are in favor of early cystectomy? Raise your hands, please.
I can't see the head, so you have to...
Don't worry, there are no hands to see.
No hands. Yeah, I already told, sir. No. That difference makes a lot of...
The point is timely cystectomy.
Yeah, timely. Selection of case, timely cystectomy. That window...
that is not described very well. I think it's not about early cystectomy, it's timely.
Timely.
So probably when, first line of therapy fails and the patient is put on second line and he fails that's probably the right time to offer cystectomy.
Cystectomy as and when required.
Yeah.
Yeah.
No argument there.
The strong indication is there. We have to think of it. Thank you very much. I thank both the debaters. Next.
Debates like this remind us that medicine is both science and art. Thank you very much to both.
Vijay Simha.
Thank you so much for giving me the opportunity. Thank you, Vivek.
We request Dr. Ravi Divakar sir to kindly join in chairing this session. Throughout today's sessions, we have discussed surgical strategies and decision-making in bladder cancer. However, management of muscle-invasive bladder cancer increasingly relies on systemic therapies that complement surgeries. And to help us understand this, we welcome Dr. Vijay Simha, consultant medical oncologist at Shankara Cancer Hospital. Over to you, sir.
Good afternoon, one and all. Thank you very much. Thanks for this opportunity. Am I audible? So I thank Dr. Srivatsa sir for giving me an opportunity to present this topic. It is one of the hottest topics probably in urinary bladder nowadays, and I think it is the cream of all the topics today. And he has placed this responsibility on my shoulder. I hope I'll be able to do justice. So I'm a consultant here, trained as both a radiation and medical oncologist, right now practicing here as a medical oncologist. So we are talking about muscle-invasive bladder cancer. So where the tumor, once it breaches beyond the muscle, it signifies a lot of events. The probability that there is lymph node metastasis dramatically increases, the metastatic potential significantly increases, and the survival significantly drops down. And the there is a remarkable shift of management from a transurethral resection of bladder tumor to radical cystectomy. And also at the molecular level, we'll be able to appreciate that there are several changes when this particular muscle invasion of bladder cancer occurs. So when we see the management of bladder cancer, radical cystectomy still is the gold standard and the cornerstone of MIBC, and MIBC is the most common indication for radical cystectomy. However, despite it being curative, there are several nuances where the experience of the operating surgeon and the volumes of the center matters. The pelvic lymph node dissection and whether it's open or robotic, the outcomes may be similar. But despite the best curative intent treatment, what we all know from several papers and data that have been analyzed and presented is that only 50% of the patients can achieve long-term survival just with cystectomy alone. So my topic, what I'll be presenting is what can be done before or after this very valuable step in the treatment of radical cystectomy, and what can be done to improve the survival rates. It has been known since the last 2-3 decades that the best thing that can be done before doing a radical cystectomy is actually to give neoadjuvant platinum-based chemotherapy. Neoadjuvant platinum-based chemotherapy, combination chemotherapy, has been shown in meta-analysis of several thousands of patients to produce an absolute improvement in overall survival of about 5% at 5 years, and a disease-free survival of about 9% at 5 years, and causing a modest improvement in the pathologic CR to at around 28.6, around 30%. And this is the forest plot of the meta-analysis. There is no doubt that there is a decrease in the risk of death, and also there is an improvement in the absolute overall survival. However, when we use chemotherapy or any perioperative systemic therapy, there is a strict efficacy and toxicity balance. That is the reason why several chemotherapeutic agents and several regimens have failed. And as of now, platinum-based chemotherapy is the one which has shown clear and modest benefit. And in this situation, the margin for error and complications is very low. We need agents which can be added on to the platinum, but which do not cause a significant increase in the complications. So it has been known since the previous few talks that the bladder tumor is definitely a very immunogenic tumor. When we see the pathogenesis of bladder cancer, it results from continuous stimulation by carcinogens and bacterial infections, and the immune system infiltrates into the bladder, and there is continuous irritation of the bladder by the immune system, and ultimately what happens is that there is exhaustion of the immune system. The bladder is definitely infiltrated by T cells, but these T cells are exhausted. There is myeloid cell mediated immunosuppression and the fibroblast associated immune exclusion. That is, the immune cells are not allowed to effectively infiltrate the bladder. So therefore, the tumor actively evades the immune system and continues to grow. And this was recognized, and it was well appreciated that we could use immune checkpoint inhibitors. And when immune checkpoint inhibitors were used in the management of bladder cancers, we could see pathological complete response rates of as high as 36 to 46% when pembrolizumab or Nivo-AP were used in combination. But however, that could not ultimately clearly solve the problem, because there were several trials where combination of immune checkpoint inhibitors with chemotherapy actually failed. These are two instances where pembrolizumab, which has succeeded in almost many of the body parts, body cancers, has actually failed with along with the combined with chemotherapy in bladder cancer, and similarly for atezolizumab. So immune checkpoint inhibitors, we know that in urothelial cancers they are safe, active, efficacious, do not interfere with the surgical results or the actual performance of the surgery. The toxicity is predictable, as happens for the usual immune checkpoint toxicity, and the toxicity is not overlapping with chemotherapy, so there is no synergistic toxicity, and it does not interfere with the surgical results. Therefore, there was a randomized phase 3 trial, which is a path-breaking trial, where more than 1,000 patients were randomized to either durvalumab with the addition of gemcitabine plus cisplatin, which is sort of a practical and pragmatic regimen. We all know that dose-dense MVAC is a better chemotherapeutic regimen, but gemcitabine plus cisplatin is a more practical regimen. And durvalumab was added, 1,500 milligram given every 4th weekly. So that was compared to the standard arm of neoadjuvant gemcitabine plus cisplatin, which was the standard of care. Patient underwent radical cystectomy, and then after cystectomy they went on to receive durvalumab 1,500 milligram every 4 weekly to complete a year. And the primary endpoints were what were the event-free survival, the pathologic complete response, overall survival, and there were several exploratory secondary endpoints. So this particular trial was special in that it included patients who had borderline renal function. For example, according to what is called as Galsky's criteria, creatinine clearance of less than 60 is considered not suitable for platinum, but this trial allowed creatinine clearance 40 to 60, and there are almost 1/5 of the patients with this level of renal function. And also it included both PDL1 high and low negative. PDL1 has always been a confusing biomarker in urothelial cancers. People were not very convinced that it is the absolute marker to be used. So both negative and positive patients were included. And divergent histologists were also allowed to participate. So this was the results. We could see that the addition of durvalumab increased the pathological complete response by around 10%, but this was not statistically significant. However, what was the primary endpoint, which was the event-free survival, actually improved by a statistical 10%, and this led to a hazard ratio of 0.68, which was significant and meaningful. And not only was the event-free survival, but also the overall survival was improved with the addition of durvalumab. So the Niagara trial, which recruited more than 1,000 patients, has changed the management paradigm, and as of now, durvalumab added to the chemoimmunotherapy, probably the established standard of care in muscle invasive bladder cancer. But what about patients who are cisplatin ineligible? Whenever we are faced with a problem in the curative setting, we look back at the treatment in the advanced, that is palliative setting, and enfortumab vedotin, which is an antibody drug conjugate, in addition with pembrolizumab, had shown very good response rates of almost 70%, with complete responses of almost 30%, and doubled the survival compared to chemotherapy, compared to the usual chemotherapy. So enfortumab vedotin had established itself as a standard of care in advanced urothelial cancers. So this was then borrowed on to be used in the perioperative management. So perioperative enfortumab vedotin along with pembrolizumab in bladder cancer, again published in New England Journal of Medicine. So it had shown an event-free survival of almost 75% compared to 40% with survival with surgery alone, and an overall survival of almost 80%, which is estimated at 3 years compared to 63% alone. So also here also there is improvement in the event-free survival and overall survival with the use of perioperative enfortumab vedotin with pembrolizumab before radical cystectomy. And the pathological complete response rates were also significantly high, almost 60% compared to 8.6 with radical cystectomy on. These are the Kaplan-Meier curves of the event-free survival. And there is one more step ahead where they have recently, it was just in the last ASCO Genitourinary Symposium, it was presented that neoadjuvant and adjuvant enfortumab plus pembrolizumab in patients who are eligible for cisplatin. That is, we are now going into cisplatin eligible territory. We are going to use this combination, effective combination of enfortumab vedotin with pembrolizumab. And in the abstract form, it was shown that in cisplatin eligible also, EV plus pembrolizumab significantly improved the event-free survival. Of course, this is still in an abstract form, but definitely the landscape of management of MIBC is going to rapidly change in the coming few years. However, there are still several unanswered questions of how we can optimally add this chemo and immunotherapy. What was the exact contribution of immunotherapy in the neoadjuvant and the adjuvant setting towards the relapse-free and overall survival benefit that was obtained? Is if patient achieves a path CR and we assume that there is no tumor in the body, is it really necessary to continue the immunotherapy after achieving a path CR? How do we exactly stratify the risk of recurrence in a patient who has received perioperative chemotherapy and immunotherapy and has undergone surgery? And what is the role of adjuvant therapy, if at all, used in bladder cancer? So first, let me address this small topic of adjuvant therapy in bladder cancer. Adjuvant chemotherapy, if ever used in bladder cancer, is typically again platinum based. It is considered for patients who have high risk of relapse after upfront surgery, but because it is just modestly efficacious and significantly toxic, it has very limited use and it is a subject of debate. Therefore, adjuvant immunotherapy has been tried after radical cystectomy, and it has shown to be improving the disease-free survival compared to placebo. But however, these adjuvant immune checkpoint inhibitors have not shown improvement in overall survival. Though some analysis have suggested that in PD-L1 positive cohort, there is a significant benefit from adjuvant immunotherapy. However, nowadays, the more focus is coming on to what is called as circulating tumor DNA, which can be used to detect minimal residual disease. Now, when we want to know what is the risk of a patient who has undergone radical cystectomy to have a future recurrence, this is what we should be looking at. Minimal residual disease is initially initially a term that was coined in leukemias and lymphomas, and now we are extrapolating it into solid tumors, where we have to detect this particular disease after a definitive curative treatment. And it has been shown convincingly that circulating tumor DNA detection is a promising biomarker for detection of MRD, and it has explained the differences in the improvement in disease-free survival and overall survival, as was seen in Niagara, despite there was not significant amount of pathological complete response. So therefore, there was a ctDNA guided adjuvant atezolizumab used in muscle invasive bladder cancer. Again, a recently published paper which showed that surveillance of ctDNA post-radical cystectomy, which was done upfront, and the patients were surveilled with the ctDNA serially, and at any point of time, if the ctDNA was positive, they received atezolizumab 1680 milligram for up to 1 year versus not doing any intervention. And if the ctDNA was negative, they were just kept on follow-up. So this was a ctDNA based surveillance. Patients who had received neoadjuvant were actually allowed onto this study. So this is the survival curves for those patients who received atezolizumab after being detected to have ctDNA positive. It was shown that after even being detected to have ctDNA positivity, atezolizumab improved the disease-free survival as well as the overall survival. So on the left are the disease-free survival of those patients who had ctDNA positive either initially or even later on. If ever they tested positive for the circulating tumor DNA, atezolizumab improved the hazard for recurrence, and also it improved the hazard for death. However, if we see the survival curves of those patients who were ctDNA negative after radical cystectomy, they continued to do well, and definitely the chances of recurrence in these patients was significantly less. So to summarize my talk, perioperative systemic therapies which are added to the radical cystectomy is currently the standard of care in MIBC, and systemic therapies, if ever we choose to give, are better off added before rather than after the surgery. And immuno-oncology with durvalumab or combination of EV plus pembrolizumab have revolutionized the management of MIBC and have shown consistent overall survival improvement. And ctDNA detection after radical cystectomy is the best method to detect minimal residual disease and likely to become the future standard of care to follow up patients who have undergone radical cystectomy. Thank you so much.
Any questions? I think Dr. Vijay Sima has covered the topic quite well and extensively. Lot of new things are in progress, including the new drugs, new ways of trying to monitor what is the using the ctDNA and all. But till it becomes affordable and accessible, gemcitabine cisplatin still remains our bread and butter as of now. But in future, once it becomes more accessible, I think lot more things can happen in this setting where you have to have a better survival and get a better survival. I think as on date, the take-home thing is if you achieve probably a pathological CR and you have a ctDNA negative, then these patients are likely to do very well. So then the concentration is whether you can de-escalate treatment for those patients, and then you have to see what else you can do to improve this situation where you can bring the patients to a pathological CR or become a ctDNA negative with what more modalities you can use, both in cisplatin eligible and ineligible patients. So I think this part of the disease has got a very exciting future for all of us.
Thank you, sir, for that comprehensive overview. I request the chairperson to kindly present a token of appreciation to Dr. Vijay Sima. While technological advances are transforming surgical care, another equally important challenge remains: making advanced surgical techniques accessible and cost-effective. Robotic cystectomy represents one of the most advanced surgical procedures in uro-oncology, but optimizing costs without compromising outcome remains a key concern. To share insights into the strategies for improving cost efficiency, we invite Dr. Manish CA, Consultant Uro-Oncologist, Apollo Hospital, Bangalore.
Good afternoon, everyone. I'd like to thank Srivatsa sir for this opportunity. So let me begin with a quick question. How many of us here today believe that a robotic assisted procedure is the best minimally invasive option we have to perform a cystectomy? I'm sure many of us do. And here is the second question, and this is the uncomfortable reality. How many of our patients can actually afford this procedure? Because in many parts of the world, especially and very much in India, the problem isn't access to technology, the problem isn't the technology that is available, it is access to the very own technology. The role a radical cystectomy plays in the treatment of a patient with bladder cancer, be it a muscle invasive or a refractory non-muscle invasive bladder cancer, has been spoken about and is clearly established. And also the advantages that a robot-assisted procedure brings to the patients while performing a radical cystectomy has also been fairly established. As of today, robots are no longer a rarity in India. Many centers have them. And here is the paradox. We have the robot, we have the surgeon who is trained to perform the procedure, and yet many patients do not end up undergoing the procedure. Why? More often than not, it is the cost that is associated with it. And this is the gap that we wanted to bridge. Now, it's a common occurrence in our clinics that we come across a patient who is indicated to undergo a radical cystectomy. We sit across the table, carefully counsel the patient to undergo a radical cystectomy, and the patient even is convinced to undergo a radical cystectomy. We then talk about the different modalities of surgery that is available. We explain open cystectomy, a laparoscopic or a robotic cystectomy. And then comes the question, doctor, what is the cost difference among these procedures? And suddenly the narrative and the conversation becomes less clinical and more financial. And unfortunately, many patients who could probably benefit from robotic assisted procedure do not end up undergoing the same because of the financial constraints that are associated. So we just asked ourselves a question. Could we challenge some of our routine robotic habits, step a little outside our robotic comfort zone, not compromising oncological outcomes or safety, and just rethink how we use the robot and the consumables that are associated with it. Over the past few years, while performing a radical cystectomy, a robotic radical cystectomy and an Ileal conduit, Dr. Srivatsa and his team have just included or incorporated some small modifications that are aimed purely at cost optimization. Now, these modifications have no exotic tricks, no expensive gadgets, just thoughtful adjustments. And interestingly, when we added up the numbers, we identified that a minimum of at least 1.4 lakh rupees, and this could go up to even 2.4 lakh rupees based on surgeon comfort or preferences, could be saved per case. And remember, very much in India, for many patients, this difference alone can decide if the patient is undergoing a robotic procedure or not. So standard practices generally while performing a radical cystectomy, like I said, depending on the surgeon comfort or preference as well as institutional protocols, we end up using 4 to 6 robotic instruments for the procedure. We use an energy device, generally a laparoscopic or a robotic energy device to control the lateral pedicles. And we use extra instruments like maybe a cardia forceps or the prograsp to handle the bowel. And also we use intracorporeal laparoscopic or robotic staplers while fashioning the ileal conduit for ileal segmentation, the mesentery, dividing the mesentery, as well as reanastomosis. Some simple steps that have been incorporated consistently in our workflow is that any patient, I think in the last 3 years who have undergone a radical cystectomy, only 3 robotic instruments are used while performing a robotic radical cystectomy. That is, we use a large needle driver, a prograsp, and a monopolar scissor. There is no, not prograsp, a large needle driver, monopolar scissors, and a fenestrated bipolar. No prograsp or a cardia forceps. For the lateral pedicle control, we use an anatomical dissection. The anatomy here has shown to be fairly consistent. And since it is a part of our workflow from a long time, any surgeon in the team who's performing this step could probably replicate it easily. And by skeletonizing the vessels, we are able to confidently take them between a Hemalock clip or a metal clip. Now, during the important part, that is during the ileal conduit isolation, for the ileal segmentation, we perform a double discard. Now, there's a short video that shows how this is done. And apart from or beyond cost optimization, the other advantages with this double discard is that since we do not have an extra instrument, it gives us leverage to handle the bowel with the help of the discard segments with the help of the laparoscopic assistant ports. Also, when we perform a discard, we have a horizontal section on the V-centry flush to the serosal border of the mesenteric border of the ileum. This again prevents extra compromise as compared to a vertical incision on the mesentery. Now, because of the discards, you have increased length on the conduit mesentery. Now, apart from cost optimization, there are two extra advantages. That it enhances the mobility of the conduit. And this we've particularly seen to be helpful in patients who are obese, healthy patients, where the conduit has to travel a larger segment of the abdominal wall, and patients with short and thick mesentery, where we are able to optimize the proximal discard and mature the conduit without any stress on the mesentery. All of this, along with an extracorporeal hand-sewn anastomosis just for the ileo-ileal continuity, helps us mitigates the use of maybe 4 to 5 laparoscopic or robotic fires intraoperatively, which again help bring down the operating cost significantly. This is just a small video that demonstrates I just have a 2-minute or 3-minute video of a standard radical cystectomy, which is just highlighting the steps that I spoke about for cost optimization. बस वीडियो ಬರ್ತಿಲ್ಲ ಪ್ರೆಸೆಂಟೇಷನ್ ಅಲ್ಲೂ ಇದೆ It's there on my presentation. If you no, now because that was not coming. It's there on that slide. It's embedded. It just has to stream from it.
It's asking request generate.
Sorry for that delay. So this is a standard radical cystectomy with just the cost optimization steps that have been highlighted. Play ಮಾಡ್ತೀರಾ? No. ಶೇರ್ ಆಗ್ತಿಲ್ಲ ನೋಡಿ ಬಂದಿರೋ Yeah, so we use a standard 4+2 port placement, 4 robotic ports with 2 assistant ports, side docking of the robot to prevent long lithotomy hours, 3 instruments for the entire procedure, a large needle driver, monopolar scissors and a fenestrated bipolar. Now, as we begin lateral pedicle dissection, the ureters at this point are dissected up to the VUJ. They are not disconnected, they are left draining till the end of the procedure. This is how we take the lateral pedicles in the lateral vesicle space. We skeletonize the superior vesicle pedicle, the middle vesicle vein, as well as the inferior vesicle pedicle, and they are confidently taken between a hemlock clip and a metal clip. Just for the vein, to prevent slippage of the metal clip, we use 2 hemlock clips. The anatomy, like I said here, is fairly consistent, and since it is a part of our workflow, it is consistently performed this way. I agree that in obese patients, it may not be easy to skeletonize the vessels as such, but we have been able to still isolate the pedicles and take them between clips. Now, this whole procedure helps mitigate the use of an energy device, be it a laparoscopic, a ligashore, or a robotic vessel sealer to take down the pedicles safely. So this is a panned out view showing the lateral vesicle space with your iliacs laterally and the ureter medially. And zooming in, we can see the anterior division of the iliac artery, the obliterated umbilical with the superior vesicle artery, and the middle vesicle vein. Now so as we finish off the cystectomy, the ureter is divided between two free ties and the cut margin is sent for a frozen section. This may not add to cost much, but the idea was to incorporate every small possible step that could help optimize costs. Now for conduit segment isolation, remember that we do not have an extra instrument, so these marking sutures become very important. There's a clear nomenclature in the workflow. That is, all the proximal ends are marked purple, that is with Vicryl, and all the distal ends with silk, so there is no confusion in the orientation later. Now this is the discard that I was talking about. When we when we cut the ileal segments, the discard is performed as a horizontal section on the mesentery flush to the serosal border. So this gives us, like I was saying, we can handle the bowel with the help of laparoscopic instruments with using the discard segment. And also, it is that extra length that the discard gives which enhances the mobility on the conduit also. One other thing is, because there is extra length on the conduit mesentery, your proximal end of the closed conduit ends up not being very close to the ileoilean anastomosis. This could possibly mitigate the fistula formations in the future. So now the discard segments or the ileal segments have to be closed off for the rest of the procedure to prevent leaks. So that can easily be done with the laparoscopic assistant holding the discard segment, and we can run them over with running sutures. Or even simply just hold the discard segment and we can tie off the end with a free tie. Now all of these simple modifications again help in mitigating the use of two robotic or laparoscopic staple fires, which again bring down the cost significantly. Now this is a demonstration of a double layered closure of the proximal end of the conduit. Again, because of the lack of the extra instrument, maybe a Cadier or Progress forceps, the marking and the alignment sutures become important. Since the team is, it is introduced as a part of the workflow and the team is well versed in this step, the alignment is helped by the two laparoscopic ports which keep the proximal end aligned as the double layered closure is completed on the console. And finally, for the last part of the intracorporeal procedure, and the most important one maybe, that is the uretroileal anastomosis. Again, marking and alignment sutures become important with the help from the assistant ports, and very careful handling of probably just the periuretral tissue and not handling the mucosa on the ileum or the ureter. We complete off the uretroileal anastomosis in an interrupted fashion with the use of only two robotic instruments. The anastomosis is splinted with an infant feeding tube, and the other layer of anastomosis is completed, and the same is repeated on the other side. Next slide. So for the specimen extraction, we use a 3 centimeter, sometimes 2.5 or maximum 3 centimeter left paramedian incision. Now left paramedian incision because we don't want the incision or the suture line to interfere with the stoma bag. But the abdomen is open in the midline. So we basically create a skin flap and open the abdomen in the midline. Once the specimen is retrieved, this is how it looks. These are the discard segments, and see the discard segments mesentery is the increased length on the mesentery which enhances the mobility of the conduit itself. Once the specimen is extracted, the discard ends are cut flush to the healthy vascular area of the ileum, and the ileum is anastomosed with an end-to-end hand-sewn anastomosis. This is the 3 centimeter paramedian incision that I was talking to, and the abdomen is opened in the midline after raising a skin flap. So all of these maneuvers help reducing or mitigating the use of 4 to 5 intracorporeal staple fires, which definitely bring down the cost significantly. And when we put these numbers onto the table, based on institutional protocol or the number of instruments that are used on practice, a minimum of at least 1.35 to 1.4 lakh rupees can be saved per case, and this can go up to even 2.5 lakh based on the number of instruments that are used per se. All the sources for the prices were from the Da Vinci instrument catalog. When we looked at the numbers of how the patients were doing, these were analysis done more than 6 months back, but 81 patients had undergone the procedure, and the console time and the blood loss seemed to be stable. And in fact, for 9 patients, we observed 6 of them who were healthy and had a larger abdominal wall, and 3 patients with short and thick mesentery. With the help of optimization of the proximal discard, we were able to bring out the conduit more easily without compromising or tension on the mesentery. So all of this described ways to optimize cost intraoperatively, but definitely the story doesn't end here. There are other ways, that is everything that happens in the perioperative workflow, everything that happens before and after the procedure also have an impact on the care of cost. On the cost of care. So we know prehabilitation and ERAS, we are all aware of it. It is very important, but when implemented strictly and consistently and is a part of a routine workflow, it obviously means patients mobilize faster, bowel function recovers faster, lesser hospital stay, and lesser cost of care eventually. Workflow optimization is important because in complex cases like a radical cystectomy, it is not just about the surgeon alone, it is about the whole operating room ecosystem. So same team with the same workflow practicing means doing the case repeatedly. Everyone knows their steps. The surgery time obviously becomes efficient, anesthesia time reduces, and that also helps in bringing down the cost. In some patients where we cannot afford a longer anesthesia time and well-selected patients, that is lean patients, where there is not much advantage of an intracorporeal ileal conduit, the cystectomy can even be completed with just 2 instruments, that is a bipolar and a scissors, and the extracorporeal ileal conduit could be fashioned. So the bigger picture, it is a cost optimization in a radical cystectomy is a multi-layered approach. Everything before, after, and during surgery matters. And I think by incorporating these small methods, we go one step closer to the ultimate goal, that is making advanced robotic surgery more accessible to patients, because ultimately the goal is not just the availability or the success of surgical innovation is not just availability of the technology, but to the number of patients it can actually benefit. Thank you.
Thank you, Manish, for a very good innovative idea. What is the problem with management? Yeah, no, management means people who buy the robot and they are looking for...
No, but at least we are able to serve more patients. So a number of cases are still happening. We may optimize cost per case, but I'm just saying it makes it more accessible to more number of patients.
Can you use all the robots? For all? Only
I mean,
Divans?
we are just not using...
Your Divans?
Yeah, Da Vinci, sir.
No, other robots?
Other robots, you try not to use more adjunct instruments. It may be difficult, but it is still possible is what we are saying. And second, the ileal anastomosis alone done extracorporeally with the discard, all your intracorporeal staple fire cost is reduced. So that has nothing to do with the robot.
Floor discussion. Many of you are doing robotic surgery now. I think you have to contribute something for this.
Only one difference is we remove the cystectomy. We remove the bladder through a small incision.
So, can I ask?
No, we remove the bladder as soon as this one cystectomy. As soon as cystectomy is done with the lymph nodes, we remove with a small incision. Most of the work, bladder work, bowel work can be done even extracorporeally. Even neo-bladders we have done and put it inside and do completely. So this is most of the Indian centers are doing like this only. Unless cost is a problem. Many people use even 5-6 staplers. So that may not be required, all the cases.
I have few questions for you. So you did anastomosis extracorporeal and then the conduit intracorporeal, right? How does it help any outcome?
Doing the ileal outside, sir.
You did ileal outside.
Yes.
And then you did the conduit part inside,
Yes,
right? The ureteroileals inside.
Yes, sir.
How does it help you?
No, basically all the advantages that an intracorporeal ileal conduit has in healthy obese patients where it is difficult to exteriorize the bowel segment and ureteroileal becomes difficult.
Correct.
Now it is in those patients where we are still able to do an intracorporeal ileal conduit, but help reduce the cost without using the staples.
Correct. Correct.
Can I answer that?
Yeah.
It's very difficult to do ureteroileal anastomosis outside with a small incision in an obese patient.
True, sir.
You end up pulling the ureter outside. You end up devascularizing the left ureter particularly more. Chance of ureteroileal strictures are more. So doing intracorporeally is better. That is the advantage of robotic.
So I'll share my experience. So did you use ICG in your patients? Okay. So our stricture rates have majorly come down. We credit it to ICG because we are seeing it happen again with Mantra robot.
Use mic, please.
So with the newer Mantra robot, if you start doing this same surgery with Mantra, you will immediately save 1 lakh, immediately. Because the instruments run 25 cases and then there is still no limit to them, right? And the capex cost is half of your Da Vinci. So if you really want to save in 1 second all your costs, just switch to Mantra. I do one Mantra, but my shoulders suffer somewhat because the arms don't, the needle driver won't move 360 degrees. It doesn't have active motor movements when you open the jaws, all those things. Still, it will be cheaper. But my question is, in a regular case, you can, whether the incision is 3 centimeter or 5 centimeter, it doesn't really make a difference. The idea, the trials that proved intracorporeal anastomosis actually works better. The stricture rates are same between ECUD and ICUD. The real advantages came with ICG in small series, and we have practically seen it. We can see a black ureter in front of our eyes in some cases. When you do half of it extra, half of it intra, the only proven advantage was less ileus rates. That was the main advantage of ICUD, that the ileus and gastrointestinal complication rates had gone down, if you look at trials.
Understood.
So if you do half of it out, you're not gaining any of that.
Not half of it, sir. Just the ileo.
I know. But you opened it, pulled
I'm not
it
even
out.
pulling out the
I
rest
agree,
of
I agree. But that's what the complete intracorporeal guys sold all this while. You go to any conference abroad, this is what they will tell you, that the stricture rates are same, but the gastrointestinal complication rates are less. For that, they claim don't open the abdomen. Some will even claim the recurrence rates are less. So I don't know how it works, but I mean, just my...
Second thing, when I do a total intracorporeal, we give a phalangeal incision to the patient, and the incision is non-muscle cutting. So the problems what we see is the incisional hernias in these patients, which are very low. I haven't seen since we have moved to that. When you do complete intracorporeal, we just make a hole for the conduit. Otherwise, everything is intracorporeal. A specimen is taken with a non-muscle cutting incision. The advantage is there.
Ileum and the...
Everything is intracorporeal.
With staplers.
Staplers. So, overall, somewhere you will benefit, somewhere you will...
I can tell what Studer told before dying. So he came to RJCI for a small visit, and then it's published also. So what he told us was 2 things to change, and we are following it. One was, he said, don't use staplers. Why? Because he proved it in some rat or I don't know which animal model study, that once you do a stapled anastomosis, because the electrical impulses now start traveling in a weird fashion, it delays recovery. So since that day, in our institute has gone completely Hansium, right? So it works. Hansium works. The ileus rates are good. The other thing he unofficially told, and it's published in his paper, we started giving neostigmine every 5. I don't know, do you do that?
Not routinely.
Not routinely. He told us unofficially, give neostigmine 0.5 mg subcut every 5 hours. Provect, which is prucalopride, 2 milligram every day. So that preferentially acts on the large gut. So the major ileus rates, which were 15% before, went down to under 10%. So that's one thing he unofficially told. The other thing he told us was use 2-layer ureteroileal anastomosis. So ureteric mucosa to bowel and then peritoneal layer above it. And
it is very difficult to see. Studer used to do a lot of things which we don't follow with ERAS. Studer used to put a gastrostomy tube.
Yes.
He was against even putting nasogastric tube.
True, sir.
Nowadays with ERAS protocol and all, many people do not put it, or one or 2 days they will remove it.
True, sir.
The point about the stapler, I don't know about the electrical impulses, but what I can tell you is that end-to-end anastomosis is always better than the side.
Agreed.
In terms of recovery of peristalsis.
True.
So, barring the fact that the anastomotic opening might be edematous and then a little narrow initially, end-to-end is always better than a side.
Yeah, and that's what he's told as well. And we practically see it. Yeah, we practically see it. So, I mean, but yeah, switch to mantra if you really want.
Okay, thank you, Manish.
Thank you very much to everyone. Request the chairperson to kindly hand over a token of appreciation to Dr. Manish. We request Dr. Raghunath sir to kindly hand over a token of appreciation to Dr. Ratkal. And there again, the exciting semi-live surgical demonstrations come, offering valuable insights into advanced reconstructive techniques following cystectomy. This session is chaired by Dr. Sanjay Adla, Senior Consultant Uro-Oncologist, Apollo Hospitals, Hyderabad. Left. Dr. Srinath N, Professor HOD, Department of Urology, RMCH Bangalore, and Dr. Sanjay Paruchuri, who is Professor HOD, Department of Urology, Vaidehi Medical College, Bangalore. We request you to come over to the dais. And robotic radical cystectomy becoming the preferred approach in many centers because of its precision and minimally invasive advantages. And to demonstrate this, we invite Dr. Furqan Ahmed, consultant at Sri Shankara Cancer Hospital. And meanwhile, we do have a working little tea break. So a few of you can take turns and come back. Thank you.
Yeah. Good afternoon, everybody. So I'll be talking about robotic radical cystectomy. Part of it has been discussed by Manish. So like he said, we use only 3 instruments. Our ports are placed a bit high up in a straight line, basically because we do our urethroileal anastomosis intracorporeal. That is why it's kept in a straight line and a bit further away. And it also makes it easier to handle the bowel. Yeah. So the other thing is, so we do both side docking and end-on docking. So side docking, basically if a patient has had some hip replacement or knee replacement surgery, so we do side docking for those patients. Otherwise, generally we do an end-on docking with a steep Trendelenburg in a lithotomy position. I'll be demonstrating what we do at Shankara, how we do our radical cystectomies. Brief overview, we do a ureteric dissection first, then we control the pedicles, then we do the posterior dissection, then the bladder drop and division of DVC, and then we clamp and divide the ureters later on, and then the urethra is divided in the end, followed by suturing of the DVC. Yeah, start the video. So, starting with the ureteric dissection. Yeah, starting with the ureteric dissection. So we leave a strip of peritoneum over the ureter so that we have good blood supply over the ureter. At the same time, it helps in the orientation of the ureter, especially on the left side when we tunnel it across to the right side under the sigmoid mesocolon. At the same time, it helps in the orientation on the right side when we do our intracorporeal anastomosis. Coming to the control of the bladder pedicle, so we've gone just to the lateral pelvic wall, just beyond the obliterated umbilical artery, and we're going to work along the lateral pelvic wall, low down, till we hit the. Then we're going just at the level of the ureter. All the way down, just lateral to the ureter, all the way down to the pelvic wall. So whatever tissue we have in between this pedicle is, in between whatever we've dissected is our pedicle. So I think Manish has shown that we've clipped the ureter, we've clipped the superior vesical artery and all. Here we've basically, we're dissecting the middle vesical vein. So here, this is the only structure that will be clipped. Generally, we do clip the arteries also, but here in this video, we've only clipped the middle vesical vein. All the other structures are buzzed with the bipolar and monopolar, like you see here. So we follow these steps basically so that it's easy for our fellows to also replicate the same steps while they do their cystectomies. So we're pretty much done. These are just whatever minimal attachments that are left. So I've only shown one side. Same step will be followed on the opposite side. So, yeah. Now we go to the posterior dissection where the peritoneum is incised, and then the Denon-Villiers fascia will be incised, and then we do the posterior here. It's being incised, and we go along on the mesorectum all the way down till the prostatic urethra. You can see the perirectal fat being exposed. And this connects to our previous dissection done laterally. So now comes our very simple step, which is the bladder drop. So bladder has been dropped and all the way down. This is a vas on the left side being divided. So this is the endopelvic fascia being divided on the left side, and here we're just going towards the DVC. So bladder drop is pretty much completed here. So we raise the pneumo to 20, and then we proceed with cutting the DVC. So in our practice, we always cut the DVC. We don't ligate it. So our urethra has been exposed, and it'll be skeletonized 360. You can see the bipolar go across. So this is the point of time where we clip the ureters, and we divide the ureter, and we send a frozen section on both the sides. Yeah. So now comes the division of the urethra. So this is what we do to prevent any urinary spillage. After the urethra is divided, we clip the catheter. Yeah. So, yeah. So we always bag the specimen, and this will be the last part where we suture the DVC. So we use monocryl. We've not had any issues with it. The DVC has been sutured and going to be ligated. Yeah. After this, we'll be sending the urethral margin, and then we get the left ureter to the right side under the sigmoid mesocolon. Yeah. Fine. Thank you. Go in.
Thank you very much, sir, for that excellent demonstration. Following cystectomy, urinary diversion is a crucial step in restoring function and quality of life. One of the commonly performed options in this situation is the ileal conduit diversion. So to demonstrate this technique of intracorporeal ileal conduit diversion, we invite Dr. Tejas C., consultant uro-oncologist at Manipal Hospital, Bengaluru.
At the outset, I thank Dr. Srivatsa for giving me an opportunity. So he has asked me to discuss about the techniques of doing a intracorporeal robotic ileal conduit. So before going ahead with the steps of robotic ileal conduit, the most common type of ureteroileal anastomosis that we always do is either a Bricker or the Wallace. So I keep doing only the Bricker, I don't do the Wallace. So coming to the step-by-step, the first step is always the harvesting of the bowel. The second one is the ileo-ileal bowel anastomosis. Third would be ureteroileal anastomosis. This is mainly by Bricker. And the step 4 is the maturation. So these are the robotic instruments I use. Scissor, fenestrated bipolar, needle holder, Cadier and a ProGrasp. The endo-GI stapler I use is triple row 60 white color J&J, 2 in number, and a triple row 60 blue color J&J, which are 3 in number. And the sutures I use mainly for anastomosis is Stratafix 40. This is a small video of intracorporeal diversion. So after a patient, after the ureters are taken under control and shifted to the right side, the steep Trendelenburg is partially reduced so that the bowel falls in the front. So now here is the demonstration where all the ureters are taken on the one side. So the most important part in doing a minimally invasive surgery is transposing the left ureter without much of a compression or on obstruction. So that requires a generous opening at the posterior to the sigmoid colon, which is demonstrated here. So if you can see, the opening is almost more than 1.5 to 2 centimeter in the retrosigmoid area. Once this is done, we always see when you take a generous incision also on the peritoneum on the anterior aspect where it comes out, so that there is no compression on it. So once this is done, you identify the ileocecal junction. So that's the ileocecal junction. The markings you can see, that's the appendix and as a cecum. So on the right hand side it's the Cadier which I'm using. This can be measured even with a ureter catheter. Whereas as you keep doing it, you know that one turn is nearing to 12 to 15 centimeter. So the distal part is taken, suture is taken with a 3-0 silk, so as a marking. The proximal part, I take Vicryl 3-0. So if you see that the one turn is almost nearing to 12 to 15 centimeter. So this is a very interesting step where I clip the epiploicae to the opposite side, so that the sigmoid colon doesn't fall on. So your assistant need not always keep pushing the sigmoid colon which falls on. So you get an adequate area to work on the right side. So if you can see, the sigmoid colon falls onto that. I take a generous incision, almost nearing about 10 to 15 centimeter. Then this is the endo-GI stapler, 60 mm. This is mainly used because it also helps in hemostasis. That is only to mark, so that you know where your assistant can push in. The step 2 is side-to-side bowel anastomosis. So you are feeding the bowel to the stapler. So here 2 staplers are used to make an adequate anastomosis. So it's almost nearing to 90 centimeter or 90 millimeter or 100 millimeter, almost 9 centimeter to 10 centimeter. And the third one is to close it. The third is uretro-ileal anastomosis by the Bicker's technique. So the distally a small opening is done so that you pass on the stents. So the proximal opening is for the left one. And the distal one is for the right one. After sending the tissue for frozen, I reapply the Hemolock so that it gives us a stability for my catheter to hold it. And then you take an incision or spatulate the ureter. The spatulation on the left side I do is up to 1.5 to 2 centimeter so that it's wide. So the first suture is taken at the level of the apex by PDS. So that this PDS will help me to hold the ureter high up. So here the stent is placed. I use 8 French infant feeding tube for it. Then an infant feeding tube is secured by 3-0 catgut. So on either side, the PDS sutures are taken so that it can be held on either side, and then a 4-0 Stratafix is used for a running suturing. Similarly, the suturing is done on the other side as well. The same is replicated on the other side as well for the right. So now you remove that. The specimen is taken from the supraumbilical incision, and this is the side for the conduit. So we do the maturation with 3-0 and 4-0 PDS sutures. Thank you so much.
Thank you, sir. Beyond ileal conduit diversion, another reconstructive option that aims to preserve a more natural urinary function is the orthotopic neo-bladder. To demonstrate intracorporeal ileal neo-bladder reconstruction, we invite Dr. Rakesh Sharma, Consultant Uro-Oncologist, BIA HCRC, Hyderabad.
Good evening to all. Thank you, Srivatsa and Shankara Cancer Hospital for this opportunity. You have any control here? Or? Yeah. Okay. So this is a female patient. You can start it off. 39-year-old lady who presented to us with hematuria. TRBT was there, done, and it was a muscle invasive. So just a little differently we do is, I'll show in the video. So this was fertility preserving. I'll just show a small clip of the cystectomy part. A small lesion, we decided to go between the uterovesical plane. And here I have not shown the complete cystectomy, it's a standard one only. Only thing, we have saved a good amount of urethra here. This is a specimen for the patient. And the bowel, we also use the staplers only. Differently, we use the Covidian one. And different from Tejas, we do mark it every time. Even in conduit also we do marking, because occasionally your visual impression can be little different. You can end up with a smaller conduit and you can have a trouble. So we always mark our length of the this thing. So standard at 15 to 20 centimeters from the IC junction, one suture is taken. Generally it's a silk suture, black one. Then we'll take one more because we'll be cutting between the two. And from there 20 centimeter will come proximally. So that will be the point for my urethro neo-bladder anastomosis. So this is the ileal segment for the neo-bladder. We are taking 20 centimeter suture, silk suture is there. And here I'll take a bite and I will mark it there. Then what we do is, the suture is there, we put it in the eye of the suture and pull the bowel segment along with that, so it helps the bowel stay there and it becomes little taut. Otherwise the bowel will keep coming down and up and you have trouble. And this also helps you doing your tension-free anastomosis of the urethra, especially in obese patients, and all, it can be very comfortable. Now from there again I am taking a 20 centimeter bowel segment for the another limb of the neo-bladder. I'll take a bite here, a marking suture. So generally the sutures are either one end long, one end short, like that. So we have our own techniques. I won't go into the detail. You can use your own way. And then around 10 to 15 centimeter for the chimney. This is a Studer technique. So the chimney is performed. And beyond that, again, we'll have the proximal ileal segment, which will be cut and which will be for the ileo-ileal anastomosis. So this is the different sutures. Sometimes we'll use, this is a PDS is used for, monocryl is used here. Here we use the energy device. We cut the bowel also directly, little different from what Tejas showed. So here we save 2 staplers, reloads. Prior marking is done similar to what Dr. Tejas did on the mesentery, and in the line of that marking only we'll cut, so that we don't cut it laterally and lose the bowel vascularity. And routinely we do ICG for the bowel segment and for the ureter also. And we put place a suprapubic port, and from there our stapler comes. It's very easy to write the bowel on the stapler. Again, the technique is same, and one fire laterally, and the ileal anastomosis continued. So this is a small Rocco type of stitch. I won't label it as exactly a Rocco, but a single layer Rocco type stitch you can say, where the bowel is fixed to the posterior urethral plate, and then we make a small cut on the bowel, and this is done with a 3-0 V-lock, 17 millimeter needle, 15 centimeter suture, and just similar to our regular prostatic anastomosis after the radical prostatectomy what we do. And now the Neo-bladder anastomosis is secured. The catheter is placed, and a 3 to 5 ml balloon is inflated and kept there. Now the formation of the Neo-bladder starts. So from the right side, we have just cut open the bowel, and we put the drain tube inside, so it doesn't cut or cause cauterization of the posterior segment of the bowel. So it is at the antimesenteric end we are cutting. So this helps in keeping the bowel straight and allowing us to cut. So this is, we are reached up to the uretrovesical area, and we try to cut antimesenteric. Only at the uretrovesical point we'll go little more medially towards the mesenteric side. So here the entire bowel is cut now, and then we put some stay sutures. This is the posterior aspect of the Neo-bladder is being constructed to keep it taut and straight. It's a long procedure. It takes some time, so you develop your own techniques, and a lot of sutures, cost, many things are there. So it will be a continuous anastomosis. Here we use a 30 centimeter V-lock sutures, 3-0, just to save on the cost, because otherwise you'll end up with double the cost if you use 15 centimeter. You can use Vicryl, but it gives the confidence with the V-lock, braided suture, barbed sutures. It stays where you leave it. So slowly and steadily you complete your total posterior anastomosis, and then the folding comes. The anterior reconstruction will start. So this is the catheter. You can see this is the uretrovesical area, and from there the folding will start. This makes the bladder in the spherical shape. Otherwise it will form a U shape if you don't do that. So this folding is done. You can see. So there will be two limbs will be there. One will be the right limb, one will be the left limb will be there. You can see that I have pulled the chimney part this side. This is the left side of the Neo-bladder. So I'll take some stay sutures. Nowadays I have stopped doing this. Is some 1 year old video, but nowadays we don't take any stay, and just I use V-lock and start closing the anterior aspect of the Neo-bladder. So this is one limb is getting closed. So we do little bit on one side and then stop and then come on the other side. This is the left side. The right side I did little bit. So in between some interrupted sutures we keep it so that you don't have to do a lot of cheating in the closure, and you have alignment of the bowel. Intermittent sutures are placed. Similarly on the other side, this is the right side of the limb getting closed now of the Neo-bladder. It will take approximately 3.5 to 4 hours. It depends how many procedures you are doing on a regular basis. That can standardize your technique, your steps, and then reduce the operative time. Otherwise, it's a very long procedure. So ideally we make two teams. One team will do the resection part, the other team will do the reconstruction part. In that also we'll take some break in between the closures. So here is the entire Neo-bladder is reconstructed. The uretero-ileal anastomosis comes in the end. Because if you do it in the initial part, the problem is it will keep on leaking urine and it will be a lot of trouble. The filling of the pelvis will happen with the urine. So you do that in the end. So this is the entire segment is closed now. A little bit is left on the left side. Yeah, left side is left. So we are completing that. Now the uretero-ileal anastomosis, the left one is placed little more distally. This is the left ureter, incised. And similarly, we also use the Stratafix in a continuous fashion. We use feeding tubes and exteriorize the feeding tubes. Take it out from the neo-bladder segment and exteriorize it. So this is the closure of the other wall. The tubes are generally removed at day 10, the feeding tubes, and catheter at day 14. You can see the anastomosis is getting closed. This is the other side, the right side. Sometimes I'll do end to side. In this case, we have done end to end. So there the tube had come out, and this is the end-to-end anastomosis. End-to-end, the problem is it becomes a very long anastomosis. Takes little more time. So one is end to side and one is end to end. And the tubes are come out, and we take a small opening in the abdomen and take out. This a leak test is done to check that there is no leak. Then some retroperitonealization of the neo-bladder will be done. Fixation. We generally fix the chimney part in the posterior aspect so that no kinking happens in the immediate post-op period and there are no spaces are there. Thank you very much. So this is a female patient we operated. The problem is she was not able to void. She was having a hypercontinence, which we generally see in the female patients. She is on CIC. Male patients generally, they have good continence and they void also. Yeah. I didn't find two patients I have done similar way, young ladies, but both are hypercontinent. The first one at least, which I did open some 7-8 years back, at least she voids intermittently. This lady, she came recently for follow-up. She is fully on CIC only. But she, no leak, nothing. There is no leak, but she is hypercontinent. No, if you do in the initial part only, the urine will start leaking.
Yeah.
And then you have a lot of trouble. It
Very
will
interesting,
fill.
yes, sir. Thank you. And my question is, have you put SPC, sir, and when do you remove
We never
all
put
those tubes?
SPCs.
You don't put SPC?
Because
in all your neo-bladders?
When we used to do in Tata, the SPC site used to leak. Because
Okay.
it is not a normal bladder. So it doesn't seal. When you take out the SPC, the site of the SPC gives trouble. So I don't do.
When we put when we reconstruct a neo-bladder, so we tend to put SPC with a small hole and separately from the bowel area, not through the anastomotic area, separately from the
So
bowel.
individual protocols, individual institutional. I had tough time with the SPCs, the SPC site leaking. So since since I have left Tata, I have never put SPC in any
When
of
do
our-
you remove your ureteric catheter, sir?
So we have two tubes. The feeding tubes are exteriorized. So initial first few days, all the urine majority will come, 90% will come in the feeding tubes. But as the ureter gets dilated because of the feeding tube, the urine starts coming through the neo-bladder and then the feeding tubes reduce and it comes in the Foley's. So day 9, day 10 generally will remove out the feeding tubes. They are fixed with catgut sutures, so remove the feeding tubes. No, sir, because they are very small opening. But the SPC, for SPC, at least I believe you should have at least 16 or 18 French tube, and that doesn't seal. And here I take a purse string suture also, you must have seen. I take a purse string suture around the feeding tube. So when we pull it, generally it stays okay. And important thing is I take out the feeding tube through the chimney part. I don't take out through the neo. So there is no filling there. There is the urine collection doesn't happen there. Because it is the ascending part. So it stays a little dry, I believe. I don't know, but we never had leak. Thank you, sir.
Thank you very much, sir. It was very insightful. I request Dr. G.K. Venkatesh, sir, to kindly provide token of appreciation to our chairpersons. We now have a panel discussion, and this is going to be moderated by Dr. Tarun Jindal, Consultant Uro-Oncologist, Apollo Hospitals, Kolkata.
My flight is there, so I have to rush. 8 o'clock flight. No, I thought there is no you are not. Yes, sir. Because you fix up.
At the outset, let me thank Dr. Srivatsa for having me over. It's been a wonderful day. I think these kind of boot camp strategies for discussion of precise oncological issues are the way forward rather than having elaborate conferences. The topic which has been given for me today to conduct the panel discussion on is bladder cancer. I would be touching on the entire spectrum which has been discussed since the afternoon, so non-muscle invasive and going on to muscle invasive, and strategies of perioperative management of tumors surgically as well as from the perspective of medical oncologists. The panel has already been introduced. So Dr. Rakesh Sharma, he's a prominent uro-oncologist. Dr. Ramesh, sir, he's also the head of the Department of Urology at RMCH. Dr. Ravi Devakar, medical oncologist at Shankara Hospital, Dr. Sandhya, who heads the medical oncology department at the same hospital, and Dr. Supreet. So let's start with the urologist first. Dr. Jiten, thanks for joining us. So this is a standard case who comes to you with hematuria. So let's start with Dr. Jiten, who has been kind enough to join the panel. So what's your choice of imaging for somebody who has come with an ultrasound to you, saying it's approximately, say, 4 centimeter into 4 centimeter papillary bladder tumor? So what's your go-to investigation for a person with bladder tumor on an ultrasound?
Yeah, I mean, if it has been proven in an ultrasound, we usually do a CT scan. We are not into MRIs routinely at the moment.
So what's the consensus of the audience? I mean, are you comfortable with MRIs as the primary modality of investigation, or would you still go for a CT scan? With a show of hands, please. The primary modality for bladder tumors? CECT? CECT. I think we have the answer there, because we are still not very sure as to what's happening with the virus. If we are not sure, the radiologists are also not very sure. So you cannot add, as of today, probably add much weightage to virus. It's going to refine with future. I mean, once the AI comes in, probably virus is going to become bigger. But as of today, I think everybody is comfortable with doing a contrast-enhanced CT scan of the whole abdomen. Dr. Rakesh, do you believe that PET CT scan would take a prominent role, with now studies saying that if you see the SUV values, you can actually tell about the differentials of muscle invasion as well as the aggressiveness of the tumor? Do you believe PET has any role as of today for an upfront imaging?
Not really. If this gentleman had come only with an ultrasound, and probably if I have to do only one investigation, I still may consider for a PET CT, but not every time. If it is depending on the size.
So any size, that's what. So any size criteria in which you would prefer
if something
enough
like 5-6 centimeter tumor is there, and I'm sure that if only ultrasound is there, I'm sure that probably we are going to end up with a cystectomy in this guy, and I need only one test. I may consider for a PET scan. Off the guidelines, but in real practice it happens.
What about you, Jitin?
So, I mean, the whole confusion with this VIRADS is coming from UK and all this. See, if you go with your visual impression, if you go as a surgeon, go inside, look at the tumor, you are 95% accurate to tell muscle invasion, just your assessment is good enough. Plus, if you are doing an experienced resectionist like you is operating, you will get muscle.
Correct.
And so it's all moot whether muscle was there or not. I mean,
so my answer towards this is that we are still confused about PIRADS 3, PIRADS 4. VIRADS is a new kid in the block. I mean, the confusion is galore. So let's see what happens in future. But as of today, I believe CECT probably is the investigation which everybody would be comfortable with. Now, coming to the second issue. Again, for the surgeons, anybody can take this question. What kind of resections do you offer these patients? Are you doing any kind of en blocks? On block resections?
Standard TURBT. Means a smaller tumor probably. See, my only issue is always with en block is, can you deliver it completely? If you can't deliver it, again you have to cut.
You morcellate, then what's the point?
Then what's the point?
You are going towards not spilling the tumor versus spilling the tumor. What about you?
Exactly. For the case that you showed, en bloc is a waste of time. It's a big tumor. It's not going to come completely.
It's a piecemeal resection, only standard technique.
So it depends upon the scenarios, but by and large, I believe everybody is comfortable with a standard TURBT, and we believe our muscle rates are not that bad. I mean, pickup rates are really good. It depends upon your experience rather than the technique which you use. But yes, the literature does have an evidence that if you are starting from bottom down, what's the approach of en bloc is that you actually start probably from the muscle, and then you start lifting the tumor up. So probably the pickup rates are slightly higher. So that's what the literature says. But by and large, I think for Indian surgeons,
I'll add one point to your discussion. So this always happens. You take a single center RCT or single center case series, it always shows a positive result. Same thing happened with the narrowband imaging, photodynamic. The moment you make it multi-center, and that's what happened in the photo trial. And Professor Rakesh here, now he works with Imperial. The moment you do multi-center, you find it doesn't give any value.
Yes.
So similarly with en bloc, it would be an experienced surgeon doing an en bloc. How can you compare him to a non-experienced surgeon doing piecemeal?
Most of the oncolo urologists, they are not very much trained with the usage of the laser. So we are not like the laser surgeons.
No, but nonetheless, see, the thing is that if you're doing en bloc, you are already a very good resectionist.
Exactly.
So the bias is already there. So once you are doing hundreds of HOLEPs, then you are graduating slowly towards doing an en bloc with a laser or with whatever means. So you are already much experienced as compared to a standard person.
And the bar for en bloc is low. I mean, you're not doing big tumors with it. You're not doing challenging locations with it.
And by the nature of the procedure per se, I mean, you're actually digging and starting your procedure from down rather than up down. So that also probably makes a difference.
These must be well-selected cases. So in well-selected cases, always your results are going to be good.
Absolutely. I agree to that. So this is another case scenario. I think this was a part of it was discussed in the afternoon talks. So you're doing a standard TURBT, nothing very out of the blues. It's a very standard case, but you suddenly hear a noise, a boom kind of a noise while you're doing the TURBT. It was a very standard papillary tumor. Now you're seeing that the bladder is distending, though there's no problem with the distension, but it's slightly hazy, slightly oozy. It's not as it was before. What do you believe what has happened, and what are your next steps?
Maybe a bubble blast, or probably a perforation has happened because of the bubble while you are resecting, especially when you are doing a dome tumor. That can happen, dome or anterior wall tumor. So
what's going to be your next steps?
There can be a bladder rupture is there, and you are having some extraperitoneal leak probably.
So how do you actually corroborate whether, because that's going to matter if it's an extraperitoneal leak versus an intraperitoneal leak. So how do you determine that?
Generally, you will see the abdominal distending. But if your perforation is not at the dome area, then you will not have. You can just do an ultrasound and check it.
Exactly. So an all-table ultrasound will actually be able to tell you rather than the clinical examination per se. And the indirect indicators, of course, are there that your bladder will distend if it's an extraperitoneal rupture versus an intraperitoneal rupture. So Dr. Jitin,
yeah, I can add one more point to it. So there was an RCT done in CMC Vellore about monopolar versus bipolar TURBT. Bladder perforation, the occult bladder perforations are not that uncommon. So if you routinely do cystograms post TURBT, start doing it for everyone, you'll find 10% patients have got those tiny
it's micro leaks. That's
Yeah.
true. That's probably again because you're doing a deep muscular resection. There are certain micro perforations
I
which
would
tend to
actually
happen.
do nothing if I'm clinically assured it's not.
It's an
something
it's
major,
an
but-
extraperitoneal.
Yeah, just leave it.
So if it's an intraperitoneal thing, what are you going to do?
Oh, so now there are some series where even small intraperitoneal, if you do nothing, it doesn't. Because oncological outcome has already been established. You have had a perf. So it's important for register. You should have a scheme whenever you do a TURBT. So don't leave chip evacuation to the last step. So what you do is, before you aim for the deep muscle, because that's where perfs will happen, you evacuate all chips, then go for the deep muscle, because at that time if perf happens, you want to come out quickly. You don't want to leave tumor tissue inside. You don't want to spend time irrigating inside. So yeah, but if a leak has happened, if it needs repair, we will repair it.
And that's a very interesting point. I think this is something which we should actually start into our curriculum and trainage, so that clean the bladder first. I mean, perforations can happen to anybody in whatever hands. If we just clean off the superficial tissue before we go for a deep resection, that's a very good idea to teach to the fellows. And can you still repair and preserve the bladder? And what will you need? I mean, would you consider this as a T4, and would you advise chemotherapy to him?
So follow-up series of such patients have not shown massive T4 recurrences. There may be small numbers that will actually be T4 true. How much perf was there, how long you stood there, how much tumor tissue was floating around. But a lot of these patients get out fine.
Exactly. So majority. So Dr. Rakesh.
These are rare instances. You will face once or twice in your 1 or 2 years of procedures. So nobody can have a data on that, like what has happened to these patients. They are like very small numbers are there, but whatever minimal data is there, it doesn't show there is upgradation of the disease. You can happily continue with the same treatment plan what you have planned.
Absolutely.
So only thing is that if there is a perforation, is there intraperitoneal, you should just confirm that you don't have any bowel injury associated with that small bowel injury, because that can be catastrophic.
So probably you're going to put in a drain there and maybe wait.
So generally we'll put a lab port and we'll suture it off.
Perfect.
So
perfect.
The outcomes of the patient is also much faster. You can remove the catheter on a regular time. You don't have to keep the catheter very long.
Exactly. And you manage them as whatever the biopsy comes out to be, like a non-muscle invasive manner. So right, moving to the muscle invasive. So the current paradigm, we have all agreed that neoadjuvant is the sheet anchor in the management of any muscle invasive bladder cancer. So radical cystectomy alone probably gives a very poor 5-year survival. And neoadjuvant cisplatin-based chemotherapy, there's no doubt it has added to overall survival to the tune of around 5 to 8%. And what do we aim by doing a neoadjuvant chemotherapy? We want to downstage the tumor. We want to achieve PATH-CR in as many of patients as we can. And we want to increase the event-free survival and the overall survival in all our patients who are being subjected. So that's presently the gold standard of management. But how do you decide about,
Can I add one point?
Sure.
Because this adds to your first slide. This is where VIRADS comes. So this is the only indication I would do an MRI. So what happens is, for T2 disease, doing neoadjuvant or even adjuvant chemotherapy is an over-treatment. Because T2 disease can be cured by cystectomy alone.
Correct.
So here, if you have done a proper TURBT, and now you know you grossly cleared all tumor, patient goes on to have NACT, this is the time you do an MRI scan. Because if you go in with a cystoscope, you find tumor is not there, MRI scan shows everything is clear, you can actually avoid a neoadjuvant treatment, leave it for later. There have been no trials whatsoever comparing the neoadjuvant with the adjuvant systemic therapy approach. And neoadjuvant people just claim that, neoadjuvant works, it improves survival. So does adjuvant treatment. In fact, adjuvant treatment gives you a chance to avoid treatment in T2s. So you end up treating less number of patients. You can still end up giving the same avelumab, durvalumab, whatever you want to give. Do it adjuvant. There are trials on adjuvant with the same drugs which are about to mature. That data will come. So
no, I agree. I agree the point which he's making, because T2 probably does not require any kind of adjuvant treatment. That's the potential of surgery curing T1 and T2 diseases. So, but again, in a post-TURBT setting, so either you do it prior, but if you have done a TURBT, then probably it does not make sense, because virus does not stand validated in a post-TURBT setting.
Exactly. So this is where investigational thing comes in. I mean, you go in, have a look, you find a clean scar. You can compare pre and post MRIs. So this is where,
See, I had issues with patients. What scenario is given, We have done it resection. It was T2. We have done upfront cystectomy.
No tumor.
No tumor. Patient has presented.
Exactly. Yeah.
Patient has presented after 2 years, 3 years with full-blown metastasis.
No, and I'll say
So we have changed the protocol. I think all patients who are
but
T2, they go for NSC.
No, but see, it's kind of an oxymoron. So you would also have an NMIBC presenting with a lymph nodal metastasis. So that's kind of scenario. This will happen in outliers.
Because if there is no disease, you can't offer the patient what he is saying as adjuvant therapy.
No,
You
in a
not
T2
offer.
probably, I mean, you will always have outliers. You cannot have an entire dictum for the entire group. You're going to have those 2% outliers for everything, whatever we discuss. But by and large, T2 probably you can still avoid a chemotherapy as it stands as of today. Right. So, in which patients do you tend to offer an upfront cystectomy if they are eligible for a cisplatin? Do you still believe as of today, apart from the T2 ones, which you can still discuss upon, are there any other patients you would tend to avoid?
Now it is very clear. See, medical oncologists, they are not comfortable with carboplatin. Means 10 years back, we used to give to few patients, but now after repeated discussions also, it's been finalized that nobody is giving carboplatin.
Correct.
So it's cisplatin or upfront surgery. So
No,
patient
no,
who
in the
has
sense that they're cisplatin eligible.
eligible means they will go for it. Ineligible.
So in any scenarios, I mean, if you have a patient with variant histology, probably you're not going to go for
Those are the variant histology scenarios, squamous cell carcinoma or some neuroendocrine.
Exactly. So what are those scenarios for the sake of the audience? So what are the scenarios in which you would tend to offer? So a patient who has come to you with a small bladder bleeding tremendously, you're not going to wait for a chemotherapy in this particular setting. So
those emergency conditions, you have to do a cystectomy, stabilize the patient and do it. But other than that, any variant histology is there, we tend to go for a cystectomy.
Upfront cystectomy. So what's presently, so for the medical oncologist now, so what's your current practice, your go-to drug as of today, the most commonest NACT protocol that you use? So NCCN, I've quoted NCCN here for the reference. It says that DDMVAC is the drug of choice. What do you say?
No, it would be Niagara. As of today, it would be Niagara simply because of its ease of tolerance. Apart from the DDMVAC being a multi-drug chemotherapeutic regimen, which we know that only 60% not even 60% of the patients would be able to complete. Even we face issues with gemcitabine cisplatin, but in the midway, patients do become platinum ineligible. That is when this question of whether to switch to carboplatin or to hand over the patient back to the surgeon arises. But by and large, it will be Niagara.
Even for us, I mean, DDMVAC is not as tolerable as it is claimed to be. What's the opinion of the other?
I had only one patient experience. Lot of bone marrow suppression issues were there with the patient. Took a lot of time to recover. Final stage again was T0, N0, M0, but patient had real trouble during the chemotherapy sessions.
Exactly. So the myelosuppression, I mean, the trial which basically supports DDMVAC is VESPER. I discussed this with Dr. Kamath also. Their center is using DDMVAC and they say that it's very well tolerable. But to our patients, it's a disastrous regime. I mean, they're just not able to tolerate it.
Actually, before I've been practicing for quite some time. Before GemCis came, I was using DDMVAC.
DDMVAC.
Okay, for a long time. Because it's been
but not the standard MVAC therapy.
It's a MVAC therapy which what we were using compared to DDMVAC, and because of that, and if you take the compliance, I think gemcisplatin is much more compliant for patients than DDMVAC. So that's why most of us use DDMVAC. I mean gemcis as the
go-to drug. So according to VESPER, there was a response, I mean, there was a difference in the PATH-CR rates, so 42% versus 36-37%, but it did never achieve statistical significance. And this is a trial which is now a very hot trial, and it's being discussed in majority of our conferences now. And probably majority of our medical oncologists are very much inclined to move towards this. It's a combination of Durva along with your gemcis, and Durva is given perioperatively. So I will try to dissect this trial. So we all know that we had better PATH-CRs. The differences were statistically significant. What's your experience? I mean, the panel has actually moved to.
So we had some 8 to 10 patients now already. Of that, 2 have already come for surgery. Both are PATH-CR.
Wonderful, wonderful. So it's basically working for
the tolerance was also good. The first patient which we operated in the adjuvant part of the dural, he had a lot of trouble. So probably the medical oncologist had to stop.
So I'll come to that. So what about the medical oncologist? So do you think the side effects which are being now quoted in the Niagara regime are very well tolerable, the skin side effects, the pneumonitis. And the second part of the question will be, because the threshold of the administration for the GFR in this particular trial, which has been put to question, was 40. And are you comfortable with 40?
So we have been using this immunotherapy in almost even GE everywhere. It is now perioperative immunotherapy. So that way, use of immunotherapy with chemotherapy is not an issue. Okay, especially it comes like in long-term use. Whenever in adjuvant there comes a PCR and we have a patient on immunotherapy with immune-mediated toxicity. At that time, we have a discussion with the patient. Already we have achieved a PCR. So continuation, completion, another toxicity, especially adrenal insufficiency, hypophysitis, all this becomes a problem. But again, as Dr. Supreet was rightly telling, when we are on chemotherapy alone, there are times when we have to, change over because of changing creatinine clearance also.
Exactly.
So at that time, if you have a backbone of another drug, immunotherapy, which is going strong with a full dose, that is actually a backup. And considering a 10% more increase in PCR with EFS benefit, I think we are good to go and we are comfortable using that regimen.
Right. Yeah. Yeah, sure. So Dr. Rakesh has a flight. Thank you so much for joining us. Thank you. Have a safe flight back home. Thanks.
I think creatinine more than 40 is okay to start with.
And are you gonna be giving the entire dose? The way you give it, or are you gonna split it?
I generally do with extra hydration. You keep them for an extra day and hydrate. And you use the split dose cisplatin. Instead of giving 70 on day 1, you give 35 on day 1 and day 8.
Correct.
And generally, they do tolerate well. So idea is to give as much cisplatin as possible to those patients.
So another interesting, so let's dissect this trial further.
It has shown that even if you don't get PATH-CR, even downstaging the tumor is going to give you a survival benefit rather than not having any response at all.
Exactly. So once you have given, say, Durva along with Gemcis, you have had patients who have had PATH-CR versus the patients who have not had a PATH-CR. Now, what's the rationale of continuing Durva in the patients who have not had a PATH-CR? So in a conventional setting, if you're given an NSCT and you find that the patient had a residual disease, Gemcis, residual disease on surgery, you would not continue Gemcis. Then why are we continuing durvalumab in this particular trial? Do you think that makes sense? To my mind, it doesn't.
No, it really makes sense, because that is all the more reason why we have to give some adjuvant therapy, because the patient did not achieve pathological complete response.
Then let's flip it. So then why are you continuing durvalumab in a patient who has achieved a PATH-CR?
So in the same trial, there was post hoc analysis that was presented on ctDNA. Now we are not even talking about PATH-CR, it is about ctDNA, wherein those who even had ctDNA negative status in the Gemcis arm versus Durva plus Gemcis arm, there also continuation of durvalumab gave survival benefit.
Right, very interesting. So you believe that ctDNA is going to make a difference, and that can actually lead to any kind of de-escalation? So if you believe somebody who has had a PATH-CR, you did a ctDNA test on him, the ctDNA comes out to be negative, would you still continue durvalumab?
So this is where the question of standardization of the ctDNA test arises. So none of the laboratories that are currently doing this test in India do not have a standardization, and it has to be done through Signetra. Signetra is in 99% of Indian patients would be inaccessible, and it has to be a tumor-informed ctDNA, which means you have to collect the DNA from the tumor itself and also do from the blood and match whichever mutations that are found on the tumor, they have to be matched on the blood as well. So these are all the real challenges that we
But again, so there's data which is emerging, and this is one of the results which were just published around 3 months back, and there's a lot of debate which is happening on this particular study, which is called RETAIN. So what they've done is that they've given a perioperative combination of IO with DDMVAC. So DDMVAC with Nivo, and they did ctDNA on all the patients. And now they have avoided radical cystectomies in patients who had ctDNA negativity after having a PATH-CR on say a combination of a chemo and durva, so chemo and IO combination. So yes, we have evidence now that ctDNA probably will help you in de-escalating. So my question about continuation of durva in a person who has had a PATH-CR versus not, so probably that's not the criteria for continuation. The criteria will be ctDNA-based criteria in future once it's available. I think there are going to be more biomarkers. Jiten, you have been in UK. What's your take on that?
So first, I agree with what sir said. I don't trust my molecular oncology, not even molecular, the basic science.
You are away from Delhi, so that's why we can still accept this. Your hospital people will kill you for this statement.
No. I told my boss, look, because I know a bit of biotech because I'm a PhD in biotech as well. So I've spent some time in labs. They quality control to everything else. You can find errors if you really know your job. We don't have very good labs right now in India. This is the reality. So I take it, I'm very cautious. Unless I verify it against a standard, I don't accept. I have had problems with all sorts of NGS tests from all sorts of vendors. And I don't want to speak bad about it. But yeah, the other thing, ctDNA. So again, I asked my basic science team to prove it to me. And now we are going to test it with American guys that are we doing it right? Because you just don't know. I mean, when feedback comes from abroad that a simple DNA contamination can go undetected,
Exactly.
the whole report turns trash. If you don't know what those guys are doing, you will be completely misguided. It happens.
True, and that similar thing happens with the pathologists also and the radiologists also.
Yeah.
So virads, pyrads, low grades, high grades, G2s.
And also the challenge that it has to be done 6 weeks once or so to see when it is becoming positive, and then you have to offer the adjuvant immunotherapy or whatever.
Yeah,
if we are going by ctDNA.
But there's going to be a era of biomarkers which is not way away from the present scenario. I think that's going to be the basis of discussion of initial therapy. So you want to make a point?
Yeah. I think that's what, as I said, it should not be tumor agnostic. It should be for that patient you have to have
Exactly.
the ctDNA
So,
signature and then do it. And I think this alone may not also be enough. You have to look at
True.
markers.
But we're going
also.
there. We are going there. In that direction, we are working. So there's data which is saying that ctDNA, with probably, the patients who do not have it, fare better. So what about cisplatin ineligible patients? So we believe almost 30%, maybe even higher, of Indian population at least, is not eligible for cisplatin in a neoadjuvant setting. And we were subjecting them majority to upfront cystectomies because they were not eligible, and the results were not as good as the patients who were eligible. So what are the options presently for these patients?
I think the option so far was immunotherapy, single agent immunotherapy. Generally, we used to use pembrolizumab. Now that enfortumab vedotin has come in combination with pembrolizumab has become the standard of care for whoever can afford that.
Correct. So this trial was also discussed, I think, by one of my previous speakers. So this initially started with pembro versus cystectomy, but pembro arm was subsequently removed, so it became cystectomy versus EV plus pembro. And this is one trial which basically found a lot of difference between the event-free survival and the overall survival in the patients who had an EV plus pembro versus patients who had cystectomy alone. Though I still believe, as of today, probably the patients who had cystectomy alone would probably now be given Nivo, at least Nivo. So this trial, the quantum of effect which you see on this Kaplan-Meier probably is going to come down. But nonetheless, it's a way forward, and it's opening something for the patients who are ineligible for anything before this particular trial came up. So any experience with pembro plus EV?
No.
So
we have just started, sir. But
you have started. So two of our patients are on pembro and EV.
Yeah.
So they have basically post cystectomy. They have just been started on that.
So if you go through the study, they say later on cycles tolerability almost 60% could not complete the adjuvant, enfortumab.
So what is the problem with pembro EV? What are the major side effects that you experience with pembro?
I do not think it's with pembro. The EV is the one which causes a lot of neuropathies and skin
problems.
Yeah,
so skin problems are exponentially high once you are adding EV to the regime, and the tolerability comes down. Initially, patients tend to tolerate, but say around 3 to 4 cycles down, these effects become problematic. So what's the quantity?
Dose it also like the original dose. We just keep it like around 60 mg. We start at 60 mg.
Okay.
It comes as 30 mg vial. So economically also it plays for us. So we start at 60 and slowly we build it up. So it is not like we want to start something full and then patient doesn't even complete the treatment, and we are just delaying the surgery as well.
So there are challenges with pembro EV. It's not as straightforward as it looks. It's not as glossy as it looks. But the quantum of PAT-CR is definitely something which raises your alarm, and probably you believe that this is something which is going to make a difference. Maybe some permutation or combination, some dose modification, some regime modification would probably bring that change that you can actually pass on the benefit of PAT-CR of this particular regime to the patients. What is the impact on surgical outcomes? I believe anybody, probably salvage cystectomies. I have done a post-Nivo. It did not make any difference. So EV plus pembro in cisplatin eligible?
Yes, there is data with B15, so which was presented in the recent ASCO, and here as well we see the consistent signal of PAT-CR rates of 56-57%, which means the regimen is good and effective.
Correct. So yeah, this is the trial which sir has been discussing. So this has been recently published as an abstract form also. So EV plus Pembro significantly improves your OS as well as EFS even in the patients who are cisplatin eligible. So do you think EV plus Pembro will be the gold standard now?
I
Looking at the amount
so.
of
yes,
and counterbalancing the side effects if you take out the cost constraints.
I believe.
Wonderful.
We need to wet our hands more, sir. I know
So
the toxicities as well.
we are going to
Yeah.
face trouble now because I think surgery for bladder is now going to be at least out in 50% of the patients who are being subjected to Pembro and EV.
I think a trial is coming on that as well.
Bad news for us.
In UK, bladder preservation is offered as an equal option if it's a 3 centimeter. All the
See,
criteria.
till the time the radiotherapists are not managing the problems of radiotherapy, it will be an equal option. So thank you so much.
It's a patient's decision. It's a patient. So this is what I find wrong in all panel discussions is we decide who agrees, and then as if it's their decision.
Exactly. And once the complication happens, burning, please go to the urologist who's going to manage that, and we do not know how to manage them. Anyways, thank you so much. I think I have stuck to my time, and it's a warm invitation to everybody to join us for the 8th annual RUFCON in Calcutta. We'll be conducting it in the month of July. Looking forward to welcoming you all. Thank you so much. Thank you so much for the fun.
Thank you, sir. We request Dr. Ravi B. Divakar, sir, to hand over the memento to Dr. Tarun Jindal. So moving on to the final scientific session of UROVERSE 2026. We are running late, but we are moving to the latest. Chairing the session will be Dr. Karthik Rishi, Consultant Radiation Oncologist, Sri Shankara Cancer Hospital, Bangalore, and Dr. Srivatsa N, Senior Urologist, Shankara Hospital, Bangalore. Trimodality therapy combining surgery, chemotherapy and radiotherapy is increasingly becoming an important bladder preserving strategy in selected patients. To discuss the current indications and future directions in trimodality therapy, we invite Dr. Harshita K, Consultant Radiation Oncologist at Sri Shankara Cancer Hospital, Bangalore. Over to you, ma'am.
Good afternoon, everyone. So today the topic is trimodality therapy. So far, a lot has been discussed about this topic in bits and pieces. So the basic concept of why a bladder preservation comes, most of these patients are diagnosed at the age of 70 years. They are either smokers, have a lot of comorbidities, so they are not really very fit enough to be taken for surgical procedures. So the question of bladder preservation arises. So who are these ideal candidates for a bladder preservation? Those with MIBC who have a strong desire to preserve their bladder or who are ineligible for surgical procedures, who have good bladder function as well as kidney functions, essentially those who are cisplatin eligible, those preferable who have less than 6 centimeters tumors, either unifocal, and no history of prior radiation or pelvic abdominal radiation. How it follows? So TURBT, maximal safe TURBT, 4 weeks later, concurrent chemoradiation, followed by 8 to 10 weeks later, a cystoscopy. If in case of residual invasive disease, a salvage cystectomy is offered, and in case of complete response, surveillance procedure is followed. So head-on studies between radical cystectomy versus trimodality therapy, there are no such direct RCTs as such, though meta-analysis and propensity matched studies have shown that they can be compared. And however, radical cystectomy is still preferred in those with bulky T3, T4 or those who have incomplete TURBT or multifocal CIS and poor bladder function or hydrouretronephrosis. A lot of studies from RTOG have been in place. Most of the take-home messages are in CTRT is feasible, where we have introduced the NACT is not really beneficial prior to CTRT, the usage of doublet chemotherapies, and GEM tolerated better than cisplatin, so GEM-cis as an alternative, and GEM with daily RT. And to summarize it, it has a complete response of about 69 to 75% with an overall survival of about 50 to 60%. Though the salvage cystectomy rates are 25 to 30%, the survival is comparable to radical cystectomy is what they say as a summary, as an overall view. Though there is some better sexual function and body image in comparison to radical cystectomy for patients who undergo CTRT. Coming to the toxicities, what we are worried about, the frequency, urgency, dysuria, all of it is true. Patients on CTRT tend to have a lot of burning, and they go up to 40 to 50% of them, and they need a lot of management. Though the recorded rates of late GU toxicity is hardly about 5 to 10%, so it still seems a feasible alternative. The follow-up after a trimodality remains the same as per even post cystectomy, but here we do have a cystoscopy which is done every 3 monthly, and the imaging and the blood test remains the same. And treatment options as recurrence stands for either intravesical therapy or salvage cystectomy or even systemic therapy. So now this is a graph which basically shows that how the crude rate of cystectomy, salvage cystectomy has reduced over time, and the red line shows the time graph of between 2005 to 2013, which shows that there is an improvement in bladder intact survival. This is attributed to the improvements in the technology as well as the systemic therapy. So what is it that we are focused on? We have better delineation now with CT, MRI, better bladder mapping at TURBT, which essentially helps us in delineating the gross disease. So this allows us to escalate. So we've moved from an era where we used to treat whole pelvis to targeted areas. So in the bladder itself, we are able to escalate the dose to higher doses to the gross tumor area safely. And this is what gives us an advantage. Again, the image-guided intensity modulated radiation, which essentially means that I can sculpt the dose to the area that I want to treat, escalate the doses to a particular area. All these help in reducing the toxicities. And along with that, I have a CBCT matching, which basically means that when I deliver a treatment, I'll be able to match it absolutely accurately with a precise, more precise delivery to the gross disease in itself. So this is one of the reasons why we can see an improvement in it. And this is what we regularly practice here also. So from there, the concept of differential PTV or adaptive daily adaptation has also risen, which means basically because of the differential filling of the bladder, which is a big nemesis for radiation, we have differential margins of 7 mm, 1 centimeter, 1.5 centimeter, and the treatment is delivered into the PTV which fits the day. Meaning whatever the bladder is within that, only that plan is used to accurately execute the treatment for that day. This helps us in escalating it as well as reducing the normal tissue. Word about the dose. So the conventional dose still stands at 64 to 66 gray, but hypofractionation also is being established. So in BC 2001 and BCON 55 in 20 has also shown that non-inferior local control, and of course definitely good compliance in those patients because lesser time for radiation, rather lesser duration of radiation. So coming to the future aspects of radiation, yes. So bladder is thought to be an immunogenic disease. So, and giving radiation enhances cell kill, releases tumor antigens, and hence there is a lot of scope with immunotherapy. So some studies have shown that with the use of durvalumab and in pembrolizumab in those patients who were ineligible for cisplatin or who were ineligible for chemotherapy, they basically showed an improvement in response rather than just giving radiation. So the most awaited study would be now atezolizumab, which is basically a CRT versus atezolizumab in localized MIBC. This may define a new bladder preservation strategy, especially by integrating immunotherapy. Only the prelim results have been shared, which is complete response rates of 70 to 80% and overall survival about 60%, but yet to be published. The Keynote 992, again, which is studying the pembrolizumab with conventional or hypofractionated RT. This again is yet to be published. So a word on EV and pembrolizumab, yes, it is a very fine line and it is preferred the first line as management in locally advanced or metastatic urothelial carcinoma. But with the complete response rate of nearly 67%, maybe there is a future role of giving consolidative RT as a part of bladder preservation in these patients rather than just taking them up for radical cystectomy. Of course, there are no trials to it, but NCCN does say that in some patients with probably M1A or in node-positive disease post immunotherapy or a chemotherapy, if they do have a response, we can consolidate this and give radiation therapy. Some other things which biomodulators which have been tried is PARP1 inhibitors and TGF-beta inhibitors. Basically, they work on the concept that these patients have DDR mutations, but these are all phase 1 studies and they do not have any further evidence to this. Some of the emerging role of molecular markers which may help us choosing patients for bladder preservation would be the EGFR mutants or ERCC2 mutants or MRC low-level, MRE11 low-level ones, or even in HER2 positive patients where it was tried with trastuzumab with chemoradiation had actually better response in comparison to those with only chemoradiation. Again, lot of higher level of T cell activation as well as 24 gene hypoxia, higher signatures have shown to be better overall outcomes. Circulating tumor DNA has been tested in NACT and surgery patients but has never been tested with radiation. So again, scope for a lot of studies. Before we conclude, this is one of the controversial topics. Lot has been said about NMIBC. It's always thought of as cystectomy is the gold standard treatment in case of BCG refractory patients. However, there are some studies which are with the trial of radiation also, though we do not have any concrete evidence as such. With the advent of immunotherapy and with even partial hypofractionated radiation and in the shorter courses of radiation are also being tried. So we yet to have seen the results. So as a take home, definitive chemoradiation becomes a valid alternative to radical cystectomy in muscle invasive bladder cancers, and modern IMRT, IGRT, adaptive RTs help in reducing the toxicities and it allows safe dose intensification. So our future direction is towards probably shorter courses of radiation, better radiosensitizers, immunomodulators, and integrating with the immunotherapy. Thank you.
That was an excellent summary, Dr. Harshita. Couple of questions.
Yes.
And a comment, of course. The question is, do you, while considering doing a trimodality therapy, want to treat the pelvis, the nodes as well?
So though prospective studies are showing about a recurrence rate of 3% or 5%, sir. Retrospective studies do not show that there is actually a need for treating T2 N0s to treat the pelvic nodal stations. In patients with T3, T4, or in a case of nodal positive, we do treat the pelvis. We find that it helps. So
it helps.
Yeah.
The second question is, now with the advent of a lot of these IO therapies, with complete PAT-CR rates on cystectomy, it looks like, cystectomies are going to get lesser and lesser, which is good for the patient. But then in a case with the PAT-CR, if we had to do a radiation therapy, what could be the strategy? Would you like to treat only the pre-treatment diseased area, or would you still want to go ahead and treat the whole bladder?
But these patients would also be those who were at high risk. So most probably these were locally advanced or metastatic to begin with, M1As, low volume metastatic patients. So it would be by a case-to-case basis. I would treat the pelvis also in these patients.
You would treat the pelvis and the whole bladder as well?
Yes, because there is not definitive evidence as to completely ignore the pelvis in a case where probably post-immunotherapy, if there is a complete response to it. Because these patients are those who would have initially probably have had a nodal stage or a T4 disease, and hence they were in the first place referred to immunotherapy to begin with. So.
Yeah,
thank you very much, ma'am, for that insightful presentation. Request the chairpersons to kindly hand over a token of appreciation to Harshita, ma'am. As they say, we save the best for the last. So while trimodality therapy addresses locally advanced disease, the challenge of managing metastatic bladder cancer continues to evolve with new systemic therapies. To discuss the latest developments in systemic therapy and emerging treatment strategies for metastatic disease, we invite Dr. Vinayak Muniratnam, Senior Medical Oncologist, Shankara Cancer Hospital. Over to you, sir.
Good evening, everyone. Thank you, Srivatsa sir, and the entire organizing team for this opportunity. So I'll be speaking about metastatic bladder cancer, how has treatment evolved. So this we already know, about 15% of cases would be metastatic at presentation. And to treat bladder cancer, advanced bladder cancer, chemotherapy was the building block of the treatment per se. So this started in about 1980s with Sternberg et al., where MVAC was the preferred regimen. And in 2000s, there was this Wandermas trial which compared Gemcis with the conventional MVAC, and they proved that it was similar. And we also saw that there was this Vesper trial, which again compared dose-dense MVAC with Gemcis, and that was also shown to be comparable to dose-dense MVAC. So we use Gemcis now simply because it is easier to use and the results are also comparable. So it did not outperform MVAC in survival, but improved the tolerability and also the results. So that was about initiating treatment. But then after treating a patient with Gemcis or MVAC, there was nothing else we could do. It was just best supportive care, or we had to wait until there was a recurrence. So there was nothing to salvage the patient. So at that point, Winflu-9, which is a Vinca alkaloid, was something which was tried more in the European region. So that was where this was tried. It showed some modest benefit, but then the world didn't catch up because there was really not much of a difference when they looked at the overall outcome. So Winflu-9 went out of favor, and then came the checkpoint era. So this started with the IMvigor 210 trial, that was the atezolizumab trial. So this opened the PD-L1 era. So this was just a phase 2 study of atezo in platinum-treated metastatic patients. So they had two cohorts. So one cohort was upfront atezo, the second was in a pre-treated population. So it did show some modest benefit, especially in the second line setting, where it showed that there was some signal towards an improved benefit. So it did improve the survival. The recurrence rates also was delayed when Pembro was used. So practice impact Pembro became the preferred post-platinum standard for many patients. So this set the stage for IMvigor set the stage. Keynote was the one which randomized post-platinum setting, and here when they looked at a subset analysis in Keynote, it showed that the ones who had a CPS of more than 10% did better as the ones who had a lesser PD-L1 score. So first line pembrolizumab in cisplatin ineligible patients. So Keynote 4.5 was in the ones who had already received platinum. Keynote 052 was in upfront setting in a cisplatin ineligible patient. So here again, if you see, the objective response rates was close to 30%. There were few complete responses. Duration of response was also okay. But later on, post this trial, this is the same graph which shows that the ones who had a CPS more than 10 did slightly better than the ones who had less than that. So, but then both these trials, atezo and Pembro, had a FDA restriction when they looked at it later on. So what they felt was these patients who were cisplatin ineligible, when they looked at it at a later point, if they had got carboplatin instead of cisplatin, they still did better when compared to immunotherapy in the first line. So they restricted it to patients who had PD-L1 CPS more than 10. The ones who had less probably still did better with the carboplatin as opposed to immunotherapy. So that was the FDA restriction for both these immunotherapy molecules in frontline. So this was what was the withdrawal. Atezo, the company itself withdrew it, and Pembro had a label refinement. So the story so far is platinum was still considered the king in first line. Recurrence immunotherapy has a role, as was shown in Keynote trial 045. But what about maintenance? So there was nothing until the Javelin came up with the maintenance. So this was the maintenance breakthrough, where the patients were given maintenance with avelumab as compared to best supportive care. So here if you see the outcome, the median overall survival literally doubled when they used maintenance avelumab. So this became the new paradigm of treatment. So for now, we had platinum in frontline and we had IO in maintenance. So what is the next logical step? We know two molecules work well, so they combined both. So this was the combination ICA era. So there were many trials which did this. IMvigor 130, Keynote 361, Durvalumab trial. All these trials combined immunotherapy with the chemo and tried, but then all the three trials failed. So the only trial which proved benefit here was Nivolumab plus Gemcis. This was the Checkmate 901. Which used Nivo plus Gemcis. Here, if you see, the median overall survival was 21.7 months, hazard ratio of 0.78, duration of response was also 37 months. Now, why did this show some benefit when the other trials failed? There is nothing very clearly mentioned, but then the only advantage of this particular trial was they used only cisplatin. They did not substitute for carbo, and they had a good maintenance arm. Apart from that, cisplatin we know is also highly immunogenic versus carboplatin. The synergy with the IO is also better. And they stopped at 4 cycles of GC. They did not continue chemotherapy for too long, relied more on maintenance. So probably these were the reasons why this trial showed benefit. So post this came the ADC breakthrough. This was in the second line setting. So EV, the 301 trial was post platinum progression. So it was in the second line, did show benefit when it was compared with chemotherapy. Again, almost doubled, hazard ratio of 0.7. So EV was the new standard in second line setting. So this we already know about EV. So the breakthrough at that time in second line was ADCs. It was not immunotherapy. And as it happens with every drug, since something proved a benefit, they tried to combine both. So they combined the ADC along with immunotherapy. So this was the new standard. We have been discussing about this since morning. So EV302 Keynote A39 was the new standard. So this, I will not discuss this in detail. We have seen this already. So the primary efficacy results of this trial, it had a median overall survival of 31.5 months, literally doubled as compared to platinum alone in the second line setting, upfront setting also. And the median progression-free survival was more than a year, overall response rates of 65%. So this became the current standard of care. And if you look at this particular trial, overall it did show benefit. Cisplatin ineligible patient showed a benefit, liver metastasis benefit, and metastatic disease also. EV Pembro was shown to be far better than cisplatin or cisplatin based chemotherapy. So this redefined the frontline entirely, and now this is the standard of care. So we have two frontline trials that changed everything now. One is the Checkmate 901, which is more practical for us probably given the cost constraints. And EV302 Keynote A39 is the ADC IO combination, which is considered the standard of care now. So these two have changed everything. So post this, we have nothing which is really of proven benefit. We have some targeted therapy. We check for FGFR. Of late, we have all started doing that. So FGFR, erdafitinib is from proof of concept to phase 3. Proof of concept was with this BLC 201 trial. And what gave the benefit was in Thor cohort 1 and cohort 2. So cohort 2 compared erdafitinib versus pembrolizumab. This was in PD-L1 naive FGFR altered disease. So when it was compared with the pembro with IO, it was not really beneficial, but then it was somewhat better as compared to pembro. So that was for erdafitinib. Apart from that, we have sacituzumab govitecan. This is targeting TROP2. So this we do use in breast cancer, but TROP2 is also expressed in about 80% of patients of breast cancer, bladder cancer. So we don't really test for TROP2, but then this drug was used in the later lines post-treatment. So there it didn't show any major benefit. And then comes HER2-neu. HER2-neu, we have seen that Destiny pan tumor where they checked at the subset with the bladder cancers. Destiny 02 did show some benefit when HER2 was altered. So this is something. Apart from that, we have disitamab vedotin. This is another HER2 directed ADC. So again, it's the same story. When some ADC is showing a benefit, the upcoming trials will always compare it with, combine it with an immunotherapy molecule and do another trial. So those are all the upcoming trials where they are combining an ADC with immunotherapy. So the current practical sequencing framework would be, one is preferred frontline, we know is EV Pembro now. For cisplatin eligible patients as an alternative, we can always consider Nivo plus Gemcis and give Nivo as maintenance. If that is also not possible, we take the classic platinum route, we give Gemcis and give maintenance avelumab. And later lines, we do molecular sequencing and probably targeted therapy would be an option. So the key takeaways, the current treatment landscape would be EV Pembro is the new standard. Molecular selection matters in later lines. And as I mentioned, HER2 ADC plus IO programs are the ones which are upcoming. So thank you. Thanks.
Sir, most of it we don't understand. So both of us had only one question, sir. Why do you keep the name of these molecules so complex?
No idea, sir. Immunotherapy does have some, say for monoclonal antibodies at least there is something to guide, but there is some new nomenclature even used for the immunotherapy which are coming up. But then details don't ask me.
Jokes apart, sir. So if a patient came to you with cisplatin eligible metastatic bladder cancer, briefly for the benefit of who are there, how would you sequence the treatments?
Cisplatin eligible or ineligible, now EV Pembro will be the standard if cost is not an issue.
So platinum is out.
Platinum is out, yes sir. EV Pembro is the new standard now. It's a chemo-free regimen. If not, then I would consider giving Nivo with Gemcis and then give Nivo as maintenance until there is a recurrence. If that is also not possible, then as I mentioned, just give avelumab as maintenance post GC. If not, just GC.
How do you see ADCs coming up? So because we see a lot of trials now with ADCs.
ADC we already have EV which we are using. Later lines HER2 we are using ADCs already. Just that there are trials which are also combining it with immunotherapy. Probably those will be in the later lines, sir. Whether they will use ADC plus IO targeting HER2 in the first line, we don't know. If it shows a good benefit later lines, they always do that. They'll bring it to the front line and check again.
PDL1 expression, would you want to do it at all?
No, sir. I personally feel there is no point of doing any PDL1 test right now.
So at no level or no point of time you would want to do a PDL1 testing?
No. If we are giving EV with the IO, there's no use at all. Pembro alone, if we want to use, then the earlier trials did show that the ones with the CPS more than 10 would have some benefit. Less than that, they did worse than the ones who were given platinum. So we would still do better with platinum.
Yeah. Any guidelines, sir? Now you have treated a metastatic bladder cancer patient, EV Pembro, PAT-CR. Would you want to de-escalate? What would be your guidance to de-escalate? Stop
PAT-CR in a metastatic setting? Yeah. No, I wouldn't stop, sir. So even
so
if there was a complete metabolic response, we would continue the same treatment.
So no role of ctDNA. If ctDNA became negative, would you want to give the patient
not in a metastatic setting, sir. No.
Not in a metastatic setting. Any role of radiation, sir? Would you refer any of these metastatic cancer patients to radiation at any point in time other than palliative?
Sir, metastatic patients, as you mentioned, probably say he is in CMR and if there is some one residue which is seen somewhere, and then maybe in those cases I would still consider radiation, or if there is a symptomatic painful site or a bone met which is still there, only those reasons.
Evidence to add radiation in these situations, there's not enough
not
data
as add, sir. Maybe case by case basis.
Thank you very much, sir. Any questions?
Thank you, sir. May I request the chairperson to kindly hand over a memento to Dr. Vinayak? We have now reached the end of the session of UROVERSE 2026, a day filled with engaging discussions, expert insights, and collaborative learning. On behalf of organizing committee, we thank all the distinguished speakers, chairpersons, moderators, and delegates for making this conference a success. Thank you all for being a part of UROVERSE 2026.
Thank you very much. And before you all leave, you have endured so much, so I must take this opportunity to thank my colleagues, the organizing team, because they have really taken a lot of brunt. The administrative team, all faculties of the hospital, very good collective effort. I'm really thankful to each and every one of them. My job was only to manage my receding hairline, and literally no stress otherwise. Thank you very much.